mortality in diabetes is born either by kidney or by heart. So it is very important to protect right from the beginning of the diagnosis of metabolic syndrome. It is very important to protect the kidneys and also to look after the cardiometabolic aspect of that given patient. So I would be talking on diabetic nephropathy. The various risk factors for diabetic nephropathy is duration of diabetes, poor glycemic control, hypertension, smoking, dyslipidemia, obesity, and the most important thing, that is family history of diabetic nephropathy or CKD. The pathophysiology, as we all know, is multimodal in diabetes. I would not be going in much detail about it. That is the main perturbations in diabetes as far as kidney is concerned: hemodynamic, metabolic, and then inflammation and fibrosis secondary to MR overactivation. Glomerular hyperfiltration or MR overactivation and oxidative stress in the form of AGs are the primary drivers of diabetic nephropathy. Just to update you about few facts, if any patient presents to you with diabetes and proteinuria, almost 60% of them are having diabetic nephropathy. If patient has retinopathy in combination to proteinuria, then 100% of the patients have diabetic nephropathy. If there is no retinopathy but still proteinuria is there, 40% can still have diabetic nephropathy. And if a patient has been diagnosed as a diabetic retinopathy and you search for nephropathy, so 20% will have overt nephropathy and 63% will have microalbuminuria. So any patient, if you happen to diagnose him with proteinuria, do evaluate his fundus also. And if any patient has been diagnosed to have retinopathy, diabetic retinopathy, on fundus examination, it is imperative to look for the nephropathy aspect as well. So how can we prevent diabetic nephropathy? The first and the foremost thing is primordial prevention. That is, primordial is you have to prevent diabetes to prevent diabetic nephropathy. So lifestyle changes, preventive measures across the society are the most important thing to prevent diabetes. Then primary prevention is, if the patient has happened to have diabetes, then you prevent that patient from having microalbuminuria. Secondary prevention is microalbuminuria to overt nephropathy, and tertiary prevention, once the patient has overt nephropathy or significant proteinuria, then you prevent that patient from developing end-stage renal disease. Now, if we see the natural history of diabetic kidney disease in type 2 diabetes, normoalbuminuria to microalbuminuria, almost 2% of the patients develop microalbuminuria every year, and from microalbuminuria to macroalbuminuria, almost 2% have progressed from micro to macro. And if we see at a cross-sectional study 15 years post-diabetes detection, almost 40% of the diabetic will have microalbuminuria or macroalbuminuria, and 30% will have decreased GFR. So it is a very significant number, and it demarcates the importance of duration of diabetes as well. So 40% with decreased GFR still will have no proteinuria. So it is not important, or it is not compulsory, or it is not imperative to have proteinuria to have diabetic nephropathy. So 40% of the patient will not have proteinuria per se, even they develop decreased GFR. Just the gist of this slide, we have short of time, so I'll not I'll not dictate the whole slide, but the gist of this slide is, if the patient has proteinuric diabetic nephropathy, the chances of microvascular complications in the form of retinopathy are more. If the patient doesn't have proteinuric diabetic nephropathy, it has been seen that these patients are prone to develop more of macrovascular complications of diabetes in the form of CV and CNS events. This metabolic memory legacy effect we have studied since a long. It has been very well demonstrated in UKPDS 10-year follow-up study. The risk ratio for intensive therapy is 0.76, and 24% reduction in microvascular complication can be seen with good initial control of diabetes. So coming on to the primary prevention of diabetic nephropathy, UKPDS advanced Kumamoto study have shown that there is almost in the range of 20 to 30% risk reduction in the form of microvascular complication. Only negative study was VADT study, which has shown no reduction in nephropathy with intensive glycemic control. Treatment of diabetic nephropathy, coming on to the secondary prevention of diabetic nephropathy, we know that these are the four important pillars in in the treatment of diabetic nephropathy once the diabetic nephropathy has already occurred. So in the initial slide, I was trying to emphasize about primary prevention, that if you have a good glycemic control, then still 20 to 30% chances are there that you will prevent primary complication or diabetic nephropathy complication in the form of proteinuria. But if the proteinuria has happened to occur, then you are bound to prevent that patient from going into end stage renal disease. So these are the four pillars of treatment of diabetic nephropathy. One is ACE-ARBs, second is SGLT2 inhibitors, third is mineralocorticoid receptor antagonist, non-steroidal, the recent addition, that is Finrenan, and the last is GLP analogs. We have been seeing DPP4 inhibitors as well. Linagliptin in Carmelina trial have shown 40% reduction in proteinuria, but as far as decrease in GFR or other indicators of renal damage have not been much studies in this trial, because it was intended for cardiac outcome, safety of linagliptin in cardiac patients. The intent was not for the renal outcome. So these are the four pillars, and we have to be very aggressive right from the beginning. We cannot rely on one pillar for the prevention of diabetic nephropathy. Earlier it was almost an sequential approach, that is, first you add ACE-ARBs. If it is not prevented, proteinuria is not decreased, then you add SGLT2 inhibitors. If again the response is not that good, then you add MRAs, mineralocorticoid receptor antagonist, if the response is not there. But nowadays the concept is more of aggressive approach, and you right from the beginning you are expected to give multi-drug therapy to the patient to prevent rate of decline in GFR to a significant level. So if we give one just RAS blockage, the rate of decline may be in the range of 4 to 6 ml per minute per year. But if you combine all these three therapies, the rate of decline might decrease to 2.5 to 3 ml per minute per year. So why the combination is more important? Because it has a synergistic effect. It is not 1 plus 1 is equal to 2, that is 1 plus 1 is equal to 3. So RAS blockage, SGLT2 inhibitor and non-steroidal mineralocorticoid receptor antagonist nowadays have shown a great advantage in preventing or progression of diabetic nephropathy. So RAS blockage, the data suggests, we all know renal trial, that is an old trial, time-tested therapy. It has shown decrease 16% risk reduction. IDNT, that is with irbesartan, 20% risk reduction. Coming on to the SGLT2 inhibitors, Credence trial have shown 30% risk reduction, DAPA-CKD have shown 44% risk reduction, and EMPA-Kidney 28% risk reduction. EMPA-Kidney, because it was intended to give benefit in patients with GFR of more than 20. So the initial, the patients were already in advanced CKD stage 4 condition, or significant proteinuria was there. That is why the amount of prevention is less in EMPA-Kidney trial as compared to DAPA-Kidney and Credence trial. So we all know that this is a blockbuster drug, and it has shown promising results across all the trials, and most of the trials were prematurely terminated in view of huge benefit or the primary endpoints to be achieved very early. The DAPA-CKD trial, which was the first renally intended trial after Credence trial, which brought down the GFR range from 30 to 25. That is, the patients with GFR of 25 can still be prescribed dapagliflozin. This trial is concluded with huge cardiovascular and renal safety benefits. This EMPA-Kidney trial, again I am not going to much detail, studied across 6,600 patients, and the prevention again as pertaining to cardiac patients as well as renal patients was huge. This one this one study I want to quote very importantly, that is, if at a GFR of 43 you start dapagliflozin, you can give 8 years of renal life to that patient. So starting SGLT2 early is very important. The more you delay the patient putting on SGLT2 inhibitors, the more are the chances, or the less are the chances of benefits, and more are the chances of relentless progression. So it is very important right from the beginning that you start as early as possible SGLT2 inhibitors in such patients to have more number of renal life, more years of renal life. Coming on to the mineralocorticoid receptor antagonist, we all know that steroidal, spironolactone and eplerenone. Nowadays, the finrenone has taken their place in various. We all know that there are many advantages of non-steroidal finrenone. That is one which was troublesome side effect of spironolactone, that is gynecomastia and eplerenone, which is not seen with finrenone, and it has got more MR receptor affinity or selective affinity for that matter, and with decreased incidence of side effects in the form of hyperkalemia and decreased GFR. So if we see the pooled analysis of two trials, that is Fidelity and Fidelio and Figaro, that is Fidelity pooled and multi-analysis, it has shown almost 20% risk reduction in development of end-stage renal disease, and 40% reduction as compared to MACE outcome, that is CV outcomes. And these are the individual data. I will not again be going into individual data of these two trials, that is Fidelio and Figaro. But the range, prevention or protection range was similar in both of the trials, as well as the Fidelity multi-analysis of Figaro and Fidelio. It is very important for finrenone to check for these 5 5s, that is the 5 5s of finrenone we commonly call. When you initiate a patient on finrenone, you should always check his potassium. Potassium should be less than 5. The GFR should be the square root of the square of 5, that is 25, more than 25, and you should hold the treatment if potassium rises beyond 5.5. So it should be less than 5, potassium should be less than 5, the GFR should be 25 or more, and you should not continue to give finrenone if potassium is more than 5.5. The benefits are in range of 20%, that is almost 20% reduction is seen with development of end-stage kidney disease, and 20% reduction is development of hospitalization for heart failure. So almost 1 by 5 and 1 by 5. So these are the important 5 5s of finrenone treatment. And the incidence of hyperkalemia in many of the trials have been significantly lower, that is Fidelio, Figaro and Fidelity multi-analysis trial. And these trials have shown that the requirement, the development of hyperkalemia requiring the discontinuation of drug is significantly low, in tune of 3 to 4% as compared to 8% in spironolactone arm. That is almost half as compared to spironolactone. This is another study by Agrawal et al., which was published in NDT, that is Nephrology, Dialysis and Transplantation Journal, and it has shown that the efficacy of canagliflozin versus finrenone on cardiorenal outcome was similar. That is, if we compare albumin-urea reduction and if we see cardiovascular outcome, SGLT2 inhibitors, that is canagliflozin, was studied, and they have taken the data from Fidelio DKD trial and Credence trial, and they have compared it and found that almost the hazard ratio were comparable in both the trials, that is Credence trial and Fidelio DKD trial. Coming on to the last pillar, that is GLP-1 analogs. We all know that this is now another very important molecules being used these days, in particularly in diabetic patients, but it has got renal and cardiovascular outcomes, important outcomes as well as there was SUSTAIN and LEADER pooled analysis trial, which has shown 24% reduction in albumin-urea, and the rate of decline in GFR was significantly low as compared to standard care. If we see SUSTAIN 6 trial, It has shown significant reduction in albumin-urea, but again, microalbuminuria, doubling of serum creatinine, GFR less than 45 were not that significantly low in sustained trials. So I would, this is the sustained trial, which was, sorry, not sustained, yeah, data from sustained trial, which has shown that the hazard ratio or the odd ratio were significantly lower in semaglutide arm as compared to placebo. Again, flow trial, which was intended for the kidney outcome only, it has also shown reduction in proteinuria, but also reduction in heart failure events. But as far as development of end-stage renal disease was there, it was not shown significantly important results. Still, it is an important thing for future development or in a combination therapy, because it has shown reduction in albuminuria and reduction in heart failure, hospitalization and cardiovascular outcomes. So again, semaglutide, the same result which was published in NEJM 2024, 6% risk reduction was seen as compared to placebo. So summary of pillars: RAS blockage, we all know, renal and IDNT trial, 30% risk reduction, SGLT2, 30 to 44% risk reduction, plus heart failure protection. Non-steroidal mineralocorticoid receptors, Finrenon, 20% to 14%, 20% that is end-stage renal disease reduction, 14% CV reduction, and GLP-1 receptor analogs, albuminuria reduction and weight loss. No significant development of end-stage renal disease protection was seen. Until now, flow data is still, I think, is about to come. Maybe we might get some more data regarding that. So what are the red flags for diabetic nephropathy? When you should think that the patient doesn't have diabetic nephropathy or patient has got non-diabetic kidney disease? If there is sudden increase in creatinine, say patient has creatinine of 1.4 or 1.6 in the same range for last 1.5 years, and now he present to you in next visit with a creatinine of 3, then you should always diabetic kidney disease. If there is sudden increase in proteinuria, if proteinuria suddenly jump from, say, in the range of 300 to 500 and jump to 3 grams to 4 grams, then you should think of development of some non-diabetic kidney disease. MGN and FSGS are common harbingers in such condition. If there is no evidence of diabetic retinopathy with significant proteinuria, then also you should think of non-diabetic kidney disease. If there is any hematuria, hematuria is not a thing which you expect in diabetic nephropathy. And if patient develop diabetic nephropathy within 5-year onset of type 1 diabetes, since in type 2 diabetes we cannot exactly demarcate the onset of type 2 diabetes, so it cannot be said in type 2 diabetes, but type 1 diabetes has a clear-cut starting point. So if nephropathy developed within 5 years, then you should think of non-diabetic kidney disease. So these are the KDIGO guidelines. When should you refer a patient to nephrologist, that is GFR less than 30, microalbuminuria more than 300, there is abrupt or rapid deterioration of kidney function, blood pressure is not controlled, there is red cell cast, serum potassium is not corrected with usual therapies, anemia and nephrolithiasis. These are new molecules which might be be seen in future therapies. I will not, since there is shortage of time, just to conclude the slides or my presentation. Strict glycemic control only in younger individual, short duration of diabetes with no complication. To prevent microalbuminuria and type 2 diabetes, strict glycemic control, BP should be in range of 130-80. Drug therapy include ACE, ARBs, SGLT2 and Finrenon. To prevent micro to macroalbuminuria, again the same thing. Semaglutide can still be used in obese patient. And ACE and ARBs have almost equal data and either can be used. SGLT2 inhibitors and Finrenon appears to be the most promising agent. Semaglutide in obese patients have multimodal effects. And prevention of diabetes mellitus is the most important thing to prevent diabetic nephropathy. If you put societal changes in the form of weight loss and physical activities, you might prevent diabetes, development of diabetes and future development of diabetic nephropathy. There is an old Chinese saying that good doctor relieves disease, better doctor cure disease, and superior doctor prevent diseases. Lastly, Bill Gates have told that treatment without prevention is simply unsustainable. Thank you.
Thank you, Dr. Neeraj, for an excellent talk on diabetic nephropathy, its onset, and the future management. There have been a lot of advances in last few years, which he has given in such a elaborative talk, it is actually a very exhaustive session, but he has limited it with few slides. I am sure there are going to be a few questions from the audience. I will be happy to answer a couple of them. Thank you. Any questions, please?
If
Yes, Dr. Satya from Apollo.
Thank you, Chairperson, sir. Excellent talk, sir. Chairperson has complimented. What are the red flags, sir? How do we screen for non-diabetic kidney disease? Proteinuria is very simple. USCR we do, protein is more, so we send you to nephrologist.
Sir, I have shown that slide. I'll try to, okay, now, can we have that slide presentation again? There are 4-5 red flags I have shown clearly. If there is sudden decrease in GFR or abrupt increase in serum creatinine, say patient was maintaining creatinine of 1.3, 1.5, 1.7 in the same range for a long, and suddenly he comes to you with a creatinine of 4, then you should always think of non-diabetic kidney disease. Generally, we expect a gradual increase in creatinine, not an abrupt increase in creatinine in diabetic nephropathy 1. Second, patient was having microalbuminuria or moderately increased albuminuria, and now he suddenly presents to you with nephrotic syndrome. So you know, you are following that patient, and now you know that the patient was having albuminuria in this range, but now he is presented with nephrotic syndrome. So if patient has syndromic development of nephrotic syndrome, then you should always think of non-diabetic kidney disease, because we expect patient to have gradual increase in albuminuria and not very abrupt increase in albuminuria as well. Third is, if there is any RBCs in the urine, RBCs are not expected to be in urine in patients. If patient have developed overt nephropathy or significantly albuminuria with no retinopathy, there are no other microvascular complication, but only nephro issues are there, then you should think of non-diabetic kidney disease. And lastly, if you don't expect nephropathy to be there, very early onset you develop, patient was having diabetes only in the initial phases, that is type 1 diabetes, within 5 years if patient presents to you with nephropathy, then you should think of non-diabetic kidney disease. Rest, I always screen my patients for fundus examination and then decide. If there is nephrotic presentation with no retinopathy, I always try to do a renal biopsy to demonstrate. Few may still get diabetic nephropathy in the form of nodular glomerulosclerosis. One of my patients recently got diabetic nephropathy in the form of nodular glomerulosclerosis on biopsy with no retinopathy, with just 3 months of diabetes diagnosis. So it was not diagnosis, it was not the lapse on the part, because on the part we did a biopsy, we thought of non-diabetic kidney disease, but it was a lapse on the patient part that he was not screening for his health since a long time. He must have developed diabetes maybe 10 years back. So he has developed now nephropathy, overt nephropathy with nodular glomerulosclerosis on renal biopsy. So I think you should have a fair justification with the patient. If the patient is behaving, as a clinician, we all know that if patient has retinopathy and albuminuria, then it is nephropathy. If patient doesn't have retinopathy with gross proteinuria or RBCs in the urine, you should always try to go for renal biopsy and other useful evaluations.
One of the trial has shown that membranous nephropathy is a common association with diabetic nephropathy. So if you find a gross proteinuria, it is important and mandatory to do a biopsy in those patients if there is sudden change, so that you can demonstrate the other coexistent nephro problems and treat them accordingly.
And nowadays, renal biopsy is such a safe thing that almost last 6 years I have no, almost zero complication in renal biopsy. I have performed more than 400 biopsies in this round. So it is that safe. So it is always important. My teachers have always taught me that if you are in doubt, put a needle. You should confirm it. You should give advantage to that patient. And if there is non-diabetic kidney disease, you can still treat it with other measures.
Thank you, Dr. Neeraj Jain, for an excellent talk and exhaustive session. He has limited with few slides. Otherwise, this topic is a huge topic. Every slide has got a talk. Thank you once again for a wonderful session.
Thank you to our speaker. It was a lucid presentation. Thank you to the chairpersons. I request our chairpersons to kindly come on stage with the speaker to present memento to our very first speaker of the conference. I also request member of the organizing committee, Dr. Rithi Seth, to kindly come up on stage for the memento presentation. Please join on stage, sir, ma'am. A huge round of applause for Dr. Neeraj. I request Dr. Rithi to kindly present memento to our chairpersons. Dr. Neeraj, kindly join for the memento presentation. Would like to call upon to chair our next set of chairpersons, Dr. Jyotsna Nigam. She with her? Dr. Jyotsna Nigam, Dr. Ramesh Asava, Dr. D.S. Barani. Kindly take the chair. Dr. Jyotsna Nigam, Dr. Ramesh Asava, Dr. D.S. Barani to chair the next session for Dr. Sanjeev Gulati, sir. Dr. Sanjeev Gulati here will be present online with us. Do we have CV for Dr. Sanjeev Gulati? To kindly introduce our speaker. His CV will be displayed shortly. Over to the chairperson.
Good morning. Dr. Sanjeev Gulati has done his post-graduation in radiology in Gandhi Medical College, Bhopal. Then he has done MD from Gwalior Medical College. He has fellowship in diabetes management from CMC Vellore. He has publications on NAFLD in diabetes in international journals. He has contributed many chapters in RSSDI textbook. He delivers talks in the RSSDI and national forums regularly. We welcome Dr. Sanjeev Gulati.
common. Depression and cognitive decline are more common in diabetes, and diabetes is also a risk factor for development of this. So now I'm jumping directly to my topic, which I'm going to address in detail, diabetes distress. Diabetes distress is an emotional response to burden of diabetes. It's not a disorder, it's not a depression, but more prevalent than depression. Distress fluctuate, peak with life change or life stressors or complication of diabetes. So it leads to suboptimal A1C control in patient with diabetes. So we need to aware of this emotional distress that result from relentless burden of diabetes and 24/7 into taking care of their self and taking medication. And sometime normal HbA1c level is also associated with some level of diabetes distress. How common is diabetes distress? It is seen in 1 in 4 patients with type 1 diabetes, 1 in 5 patients with insulin-treated type 2 diabetes, and 1 in 10 patients without insulin-taking diabetes. So what about, there is confusion between diabetic distress and depression. Depression is often confused with diabetic distress, both in academic, literature, and clinical practice. While depression can influence how people feel about diabetes, but it is a broader term. It affects how they feel about life in general, whereas diabetic distress is specifically related to emotional turmoil due to relentless care of diabetes. While diabetes distress and depression are separate constructs, they are risk factors for each other. This means people with depression are more prone or likely to develop diabetic distress and vice versa. How to recognize it? Patient may feel helpless, hopeless. There may be history of emotional eating. Emotional eating on the basis of mood or external cues of food. Fed up with having diabetes. Gaining weight or struggling to lose weight. They feel irritable. There is lack of desire to engage with healthcare professional. Or there is erratic blood sugar control, various hypo or hyper. Various questionnaire is available to diagnose, but open-end communication may also help to diagnose it. One word about diabetes burnout. Although diabetic distress is emotional toll from managing chronic condition, diabetes burnout is resulting from exhaustion, detachment, and neglect of self-care. Here, patient may feel helpless and they give up. They feel, I hit a wall, now I'm not going to take care of myself anymore, let it be. So they thus physically get detached from their medical condition. The 3 key dimensions about diabetes burnout is overwhelming exhaustion due to chronic condition, feeling of cynicism, they feel distressed in the process and everything seems meaningless, and detachment from self-care in the form of medication intake, physical activity, or taking care of their diabetes. So how diabetes distress or depression affect diabetes? All these emotions leads to hyperglycemia due to missing of medication, non-sticking to healthy eating plan, and not wanting to be physically active and not want to get involved in their treatment. So we need to take care of this diabetic distress and depression when we meet patient. We need to ask about emotional symptoms about diabetes, depression, or anxiety. Few slides on other fear. Fear of hypoglycemia. If fear of hypoglycemia is there, patient may avoid activities, may keep their sugar level on higher level, or may reduce their insulin of its own. So we need to discuss between the appropriate caution against diabetes and deliberating fear. Psychological barrier to insulin. Psychological barrier to insulin, say patient feel there is perceived failure. They failed in their self-management, fear of needle, weight gain, and fear of hypoglycemia. For them, insulin seems to be worsening of disease. So we need to re-educate that insulin is not punishment, but it's just in taking care of their diabetes so we can prevent worse outcome or complications. What we need to do about these depressive symptoms or diabetes-related mental disorder, we need to aware of the symptoms, we need to ask them, we need to assess the symptom, advise regarding plan what we can do. We can refer them to psychotherapist or psychiatrist if required, and we need to arrange follow-up. Few next slide detailing about this 7A model. First step is aware. Recognize emotional burden in every patient. Expect variation daily, weekly with life event. Explain the subtle sign of diabetic distress like irritability, appointment avoidance or glucose instability. Second is ask. Ask them what is hardest about diabetes for you? How has diabetes been affecting you? Many people will open up about their fear. Effective communication is key. Active listening, body language, clarity, and confirmation of the diagnosis. Just listen to the patient, avoid interruption, match verbal plus non-verbal cues, and use plain language or patient language. Because role of communication, effective communication improves survival, engagement, and outcome. And language matters. Avoid the labels diabetic, non-compliant, poor control. Instead use person with diabetes in target sugar level or above target sugar level. Remember, words can heal or harm. Second is assess. Although on ADA website various validated tools are available, in our setup we can just keep our communication open and they will reveal the various stress or anxiety associated with diabetes management. We need to advise patient you are not failing but diabetes is demanding. Normalize their reaction, provide education, reframe their queries, assist with behavioral change, explore the barrier, highlight the importance of small but achievable steps, what they can do to improve sugar level. And second is assign, if required, severe distress, depression, anxiety, eating, which requires psychotherapist or psychiatrist, we can refer patient to same. But before referral, just convey patient, referral is a partnership and not abandonment. I'm skipping this slide because of short time duration. This is new concept, dance movement psychotherapy. It has been seen in various studies that for many neurodegenerative anxiety or depression related issues, dance movement is a therapy which can improve in their metabolic control as well as their flexibility as well as their symptoms. So if patient is interested, we can advise them, they can dance on or they can, dance movement can be also a physical activity format they can include in their life. And similarly with music, they can relax, they can meditate, they can listen different type of music. So key takeaway from my lecture is, holistic care include emotional need and social circumstances. Diabetes specialists should recognize and manage psychosocial issue with psychiatric referral when necessary, address both physical and mental health in diabetes management. Education should help patients accept their condition and manage their condition. Psychoeducation about disease information, acquirement of problem solving and communication skill will help increase their self-confidence. Family and friend support is essential. One of patient came day before yesterday. He is a known diabetic patient for last 4 years. Despite of taking care, his sugar is like fluctuating level, and one episode of hyperglycemia leads to complete diabetic burnout, and he left treatment all over. So I counsel this patient. This is his patient opinion regarding his sugar. Can't we play this slide? Video is there. Okay, it's not there. Actually, he is a patient of diabetes for 4 to 5 years. Despite of taking relentless care, one episode of hypoglycemia leads to a thought that कि इतना केयर कर रहा हूँ फिर भी शुगर लो हो गई है, कभी हाई हो रही है, अब मुझे कुछ नहीं करना. And he left treatment completely for 5 to 6 months. Then he came to me because he developed further more symptoms related to uncontrolled diabetes. And actually, this is very good video. It's not available here. I'm so sorry for it. So in conclusion, integrate emotional health into every encounter, use 7A approach, and continue screening. We should treat the whole person, not just the blood glucose. Thank you very much.
Thank you, Dr. Arpana, for presenting this beautiful presentation, and very beautifully you have explained that it requires a lot of aggressive counseling as far as holistic management is concerned, and even WHO has taken the aspect of mental and social, physical health, mental and spiritual health. If there are any questions, session is open for them.
The symptoms that you mentioned for diabetic, can you hear me? The symptoms that you mentioned in diabetic distress, not too different from normal depression, they were the same symptoms.
Actually, but it can be helpful, matlab it can be relieved if we communicate with patient and discuss the barriers.
I know, Aparna, I want to finish my question. So the symptoms seem to be same. Now, it could be that he or she is having diabetic distress, but there may be a coexistent depression as well for other reasons. So we need to separate the two, or we treat him.
No, we need to sum up the two and we need to refer if patient require referral and psychotherapy, matlab pharmacotherapy for depression as well.
So,
We need to.
So now, we know that we need to differentiate the two, but the treatment remains the same for diabetic, besides your holistic approach of talking to him, and otherwise if there's medication to be given.
For treatment, we need to be well balanced, that no episode of hypos should be there or hyper should be there. We need to control their sugar first. Then we need to inculcate lifestyle changes slowly, like physical activity, diet or sleep, meditation or stress management. And if required, we need to refer patient for pharmacotherapy of depression.
Yeah.
Sorry to interrupt. As we are running short on time, we will not be taking further questions, and speakers here are available with us, so you can directly, personally interact with the speakers. So sorry for that. I request our chairpersons to kindly come up on stage. Requesting
Thank
Dr.
you,
V.
madam, for
Bharadwaj
nice
sir to
talk.
kindly come on stage for memento presentation. I request our chairpersons to present memento to our speaker. It was indeed a very lucid presentation, ma'am. A tale of two conditions, body and mind. A huge round of applause. I request our organizing chairman, Dr. Bharadwaj, to kindly present memento to our chairpersons. Thank you, chairpersons, for the patient hearing. For the next speaker, we have Dr. Rajesh Kesri with us. To chair the session, I would like to call upon Dr. M.S. Jory, Dr. Ajay Tiwari, and Dr. Pradeep Patel to kindly take their chairs and introduce Dr. Rajesh Kesri. Can we have Dr. Rajesh Kesri's? Dr. M.S. Jory, Dr. Ajay Tiwari, and Dr. Pradeep Patel to chair the next session. Introduce Dr. Rajesh Kesri to us, sir. And a humble request to kindly maintain silence while the speaker is delivering his address. Thank you. Over to the chairperson.
Hello. It's an honor to introduce our next speaker, Dr. Rajesh Kesri. He is a consultant diabetologist and director of Total Care Control Diabetes Care Center. He is member of the National Executive Committee, RSSDI, EC RSSDI Delhi chapter, treasurer of Founder Quarterly Foundation, member Governing Council Illness to Wellness. He is MD postgraduate program in diabetes management from Johns Hopkins and Scope certified bariatric physician, winner of RSSDI USP Innovation in Diabetes, multiple papers and presentations in national and international journals and conferences, and contributed chapter in RSSDI Casebook 2024. So over to Dr. Rajesh.
Thank you so much, Chairperson sir. Thank you so much for your kind introduction. And first of all, I would like to convey my thanks to Dr. Bharadwaj, Dr. Ankit Seth, and the whole organizing team of this wonderful conference, and I'm very thankful to all of you who have gathered here for this event. So I'm going to talk about a topic which is a lot heard of, probably in the social media and in the society, but somehow it is not something which we as doctors and treating physicians, diabetologists frequently pay attention to in our conversations with our patients. But what I would like to mention here is that we all know, you are seeing hundreds of patients of diabetes every day, and we all know the situation, the current situation of control of HbA1c, the average HbA1c still remains to be 8.3, 8.4. The A1C less than 7 is achieved only in 30% of patients. We concluded a study in which we screened 13,000 people in different parts of Delhi, and the average HbA1c that we found in Delhi, and these were in CGSS, group housing societies, where people have access to all the costliest of the medications, still their average HbA1c was 8.36, and similarly HbA1c less than 7% was also around 33%. So the condition, the state is dismal. We have to understand, we have to look for some avenues probably which are non-traditional avenues for us as doctors. We have to keep open our eyes and look into that, and one of those things which I personally practice, that's why I am talking to you with so much of commitment with whatever I'm going to speak. Now, when Dr. Ankit told me that, sir, what is going to be your preferred topic, I said, I'm going to speak about, I practice what I preach, I always try to do that. And so I'm going to talk about fasting in diabetes. Now, I think the term fasting actually is a misnomer. When we talk of fasting, we talk of not eating, being empty stomach. It is not like that. Fasting is actually eating right. The way we fast, we don't drink only water. Even though that is also a type of fasting, but it is very rare, it is not for everyone. But the fasting is eating right. So the way we fast, we actually should be eating that way. There's no reason for us to take 3 meals. There's no point in having breakfast, lunch, and dinner. We are not made like that. This tradition of having 3 meals a day, three major meals a day, actually came from Europe, from industrialization. They had to make their workers work in shifts. That's why this meal pattern and eating pattern was made up. But we biologically are not like that. So I'm going to talk about it. So fasting here, I would say, is rather eating right. But what happens when we have diabetes, when we have obesity, when we have all these epidemics of metabolic disorder? So this is a hypothetical patient. Now, her name and everything is hypothetical, but actually this is a real patient. This is a story of a real patient. Like I put her name, Neelima. She's around 50 years and considerably long duration of diabetes, more than 10 years, where we would prefer insulin, high blood pressure, uncontrolled diabetes, fasting blood sugar also uncontrolled, and lipid levels, LDL cholesterol also high, and NAFLD most probably here with fatty liver, increased liver enzymes. She's 94 kg, and she's on probably, in her case, the best possible oral medications, metformin, sitagliptin, dapagliflozin, telmisartan, amlodipine, atorvastatin. I'm sure that you must be having many such patients, and this is a common garden variety of patients. But you see, her HbA1c is not controlled, she is obese, she is educated, she is trying to lose weight, she is doing everything that she can, she is been to a dietitian has told her what to eat, to go into calorie restriction, she is not being able to manage that. I'm sure you must be, how many of you have encountered a similar situation? How many of you would have encountered similar situation in such patients? I'm sure. Okay, thank you. So this is an actual patient. So talking about fasting, what I propose to her is fasting. Is fasting which is feasible, which she has not done before. The way I would like to change her eating pattern, that is what we call fasting. So what is fasting? Fasting is time-limited abstention from solid foods and caloric foods to suspend energy supply to the body. Now this is very important for some period of time, either during the week or during the day. It has to be the rhythm, either it is some few days in a week or few hours in a day, we have to suspend the energy supply to our body. So why this type of fasting is important, it is doable because it is easier than just eating less. Here we don't restrict the choice of food, what the patient is going to eat, what she wants to eat. She can eat what she likes. You see, a big problem is that when you have a patient 50, 60, 70 years age, they are already well settled in life. They have married off their kids, they are doing well, they have made up their bank balances, their houses. Now, when you tell them that you drastically change everything in your life, you change the things you like to eat, you change the way you like to behave, it literally is not possible. If someone was going to come here, a young boy coming you and telling you, you know, you're doing everything wrong. Just change drastically. Don't eat this, don't eat that, get up early in the morning, go for 2 hours walk or 1 hour. So it is not feasible. So we have to find a solution, but still it should be feasible and it should be workable. Fasting is not new to us. Fasting has been there, at least in our tradition, especially in Hinduism, since ages, since thousands of years. It has been mentioned in the Vedas. It is there in Ayurveda, and it is there in Ayurveda for the purpose of health. It is mentioned that fasting helps in patients, in persons who are overweight, who are sluggish, and fasting. And there's also a mention of not fasting too much. So abstention from food also cannot be extreme. This is mentioned all well in Ayurveda. So we understood the importance of fasting. We know there are different types of fasting. There's a Ramadan fasting. There are fastings in Christians. They fast for 40 days. In Jews. And there's a very interesting Buddhist tradition of fasting, in which they have their last meal in the afternoon, and after that they don't eat anything, they take only liquids. So this is something which we call the early time restricted eating, and this is also a very old tradition. And in medicine also, in the modern medicine, fasting has known to be a therapeutic tool. It has been mentioned by Hippocrates, by Paracelsus, from the 5th century BC onwards and till today. There's a difference between fasting and starvation. This is what I started with. Intermittent fasting, it covers all different types of fasting, either diurnal or weekly. It is a voluntary, time-limited abstinence from caloric intake to trigger specific physiological metabolic benefits. Starvation is involuntary, chronic nutrient deprivation leading to metabolic suppression and lean mass degradation. So the key distinctions are intermittent fasting is a controlled therapeutic intervention, not pathological starvation, and voluntary nature and time-limited approach preserve the metabolic health while triggering beneficial adaptations. So what is the challenge? What is the biggest issue that we are trying here to solve? That while calorie restriction only is effective for glycemic control, we know, yes, it works in the short term, but it requires but the requirement is for vigilant daily monitoring and leads to significant challenges in long-term adherence for many patients. Many patients find it difficult to adhere to continuous calorie restriction because calorie intake must be vigilantly monitored every day and it should be adhered to. And studies have shown that while calorie restriction shows 100% effectiveness initially, the adherence plummets from 100% at 1 month to just 10% by the month 12. We all understand, we all must have fasted, that it is very difficult to adhere to low-calorie diets. So what are the common intermittent fasting regimens? One of the most effective is time-restricted eating. When there's a window of time, it ranges from 4 to 10 hours a day, in which the individual should be taking caloric meals. Then there is this is regulation of energy intake during the 24-hour period. And then there are alternate day fasting regimens. These are called fasting mimicking regimens. So in which there is a 24-hour fast alternating with feeding whatever patient wants ad libitum next day. Then there are also 5:2 periodic fasting, in which the patient fasts 2 days a week, 2 non-consecutive days a week, and the other days the patient has whatever the patient wants. There can be an addition of a low-calorie meal in one of the meals. So all these protocols have their own advantages, and the 5:2 periodic fasting is also considered very beneficial. There have been randomized controlled trials which have shown it to be superior to empagliflozin, to metformin, with good glycemic control and weight loss. This is one of the perhaps the most important things that we as doctors should understand. The effects of fasting, especially the type of fasting that I am talking about, that is not just daily low calorie restricted diet. It is fasting either during a window period in the day or few days a week. This brings about changes which are independent of weight loss. Because in our practice, in our understanding, we usually tie all the gains that we see in our patients to weight loss. But it has been proven in different studies, in mechanistic studies also, that these types of fasting, they bring about their results way before the weight loss has occurred, and they are not dependent on the weight loss. So why does it happen? What is the mechanism behind it? This is what we call the fasting physiology. There are two types of physiological adaptations. One is the feeding physiology, the other is the fasting physiology. What happens here is that the chronobiology of nutrition comes into play. This is a very interesting fact, and I'm going to share this with you. The fed state, we are high on insulin, there is high mTOR, and it leads to glycogen storage. In the fasting state, the insulin levels decline, autophagy is activated, repair processes begin, and there is increase of lipolysis and ketogenesis and activation of AMPK. So this usually requires 12 hours of fasting or non-caloric period. So the circadian rhythm alignment is resetting peripheral clocks and reducing hepatic gluconeogenesis, enhancing metabolic efficiency. The circadian clock in our body, there are two elements of the circadian clock. One is the master clock and the others are the peripheral clocks. The suprachiasmatic nucleus in our brain, it is considered to be the master clock of the circadian rhythm. It responds to light inputs, to light and to day and night inputs. But in spite of this, there are in all the cells of the body, in all the tissues, there are individual clock which regulate the functioning of those tissues, those organs. Now, this clock in our body actually has a winding mechanism. It winds, unwinds, and the winding and unwinding is controlled by certain proteins. So the on switch is the clock and BMLI1. This activates, these are transcription activators which activate the transcription of PER, that is period, and CRY, this is the cryptomer genes, which leads to buildup of proteins, the PER and cryoproteins, which accumulate in the cell. And as they accumulate in the cell, they shut off the on switch, that is the clock and BMLI. These were the transcription activators. When they are shut off, they don't produce more of the PER and CRY proteins. And these PER and CRY proteins, which are already built up, they slowly degrade. So once they degrade, then the switch is once again turned on. But this on and off switching of this switch of clock and BML1, it is regulated by certain inputs which are coming from peripheral tissues, and they include the fasting and the fed state. So this is how the individual transcription activation of thousands and thousands of genes in each of the cell in different tissues like the liver, muscle, fat, they all are regulated with the help of feeding and fasting mechanisms. So during feeding, the insulin rises, then mTOR pathway turns on, and body shifts into a growth and storage mode with protein synthesis and fat storage. So these are the feeding signals are daytime and growth time. During fasting, the AMPK turns on and body shifts into repair and cleanup mode, and autophagy activates, energy is conserved. Fasting signals nighttime mode. And we all know that it is very important the insulin sensitivity is maximum in the early hours of the day, in the first half of the day. And as the day progresses and night onsets, insulin sensitivity decreases. Why? Because this is the natural mechanism. We are made to digest and store nutrients in the first half of the day, and the later half of the day is meant to to utilize the nutrients that we have already consumed during the first half of the day. So what happens when we change the cycle? There's a clock confusion. Now, one important thing is that there are these clock proteins that we talked about. These clock proteins, they regulate the downstream translation and transcription of many of the proteins in different cells. But there are other pathways also which are responsible for regulating those transcription, and the feeding and fasting are very important co-regulators of that. So this is why we have to understand that feeding and fasting, they have an immense effect on cellular metabolism and all the outcomes. So the metabolic confusion, the consequences of this confusion are that the circadian clock controls thousands of genes that decide when cells use glucose, burn fat, repair DNA, divide and grow. Disruption leads to diabetes, obesity, metabolic syndrome, and accelerated aging. Now talking about studies, there are many studies, there are multiple studies, but unfortunately the number of individuals in those studies is not too much. There are studies from 50, 60 individuals to maximum 400 individuals in which the different regimens of intermittent fasting or time-restricted eating have been studied. But one thing is for sure, the result of all these studies has been positive in the result of glycemic control. They offer improved glycemic control, better HbA1c control, better fasting glucose control, and improvement in lipids, improvement in blood pressure, and there are many other pathways on which these act. So from meta-analysis, glycemic control, there's been HbA1c reduction.
Please summarize your
Okay.
paper.
So I think I have this is early, this is a groundbreaking result. This is a randomized controlled trial which has shown 80% remission rate, achieving HbA1c less than 6.5, 9.7 weight loss, and 30.3 milligram per deciliter fasting plasma glucose reduction. The benefits extend beyond glucose control to body weight, decrease in blood pressure, decrease in LDL and HDL cholesterol, better sleep, and decreasing waist circumference. Intermittent fasting or time-restricted eating together with exercise is, it confounds and it increases the effect of post-dinner glucose spikes and lowers daily insulin requirement. So time-restricted eating is safe, feasible, and sustainable. It has high adherence, it is generally safe. Medication adjustment is critical, especially in patients who are on sulfonylureas, insulin, and drugs which may cause hypoglycemia. Weight loss has been 3.73 kgs and can be greater as well. The important thing is that there is lean mass preservation. I'll just take one more minute. That most of the fasting regimens that we see, and many of the drugs also which we see, loss in lean mass together with fat, but in these regimens it has been seen in studies that there is preservation of lean mass and reduction of visceral fat. There are cardiometabolic improvements, reduction in total cholesterol, LDL cholesterol, systolic and diastolic blood pressure, decrease in ALT, AST, fatty liver index. We see anti-inflammatory effects which have been measured in studies, decrease in IFN alpha, IL-17A, adiponectin and resistin. So this same patient, the real patient, has lost 6.5 kgs in 2 months by using the time-restricted eating method, eating in an interval of 8 hours only, eating the same food that she used to eat. Safety profile and medication management we've talked about. There can be few side effects, but with their initial weakness, headaches, constipation, there can be hypoglycemia if medication is not adjusted. There are certain high-risk groups which should not be advised: pregnancy and lactation, young children and frail elderly, immunodeficient individuals, people with eating disorders or dementia, and those with traumatic brain injury. So adherence and long-term feasibility is there. Participants adhered to 94.5% of days during 12-week intervention, and it is very simple. It has sustained benefit as was shown in the early trial. The difference between intermittent fasting and continuous calorie restriction we have already talked about. So, clinical implementation guide: identify ideal candidates, start with time-restricted eating or 5:2 days, adjust medication, monitor closely and provide support. Thank you so much.
Thank you
sorry
very
I
much,
took
Dr. Rajesh. Your paper was very informative. I think there are many, many more questions, and I'll request all the participants to ask you questions during the lunch time. I thank you very much for your
So
nice presentation. It was very informative, and many, many more questions are there. When I was sitting at the back, I was asked by 3-4 persons how we can reduce your weight and this thing. Though they were not diabetic, I said, you listen the paper from the Dr. Rajesh Kesri and decide yourself.
If there are few questions,
Thank
I
you.
could take them because I have a flight. I would have to, I'm sorry, leave. Yes. If you allow, sir, if chairs, with chairs permission.
Okay.
Yes.
Now, how to control the diabetes in cases, those who keep the fast during Roja and Navratri, and there is a lot of fluctuation, patients keeps on coming and who are diabetic also. So how to control those people and what guidance to be given to those people that during period?
So one, we should start with medication. So if people are on insulin, sulfonylurea, they have higher chances of hypoglycemia. The other part of the question, the major question, was how to control diabetes during these fasts. These fasts are different. Even Navratri fast in Delhi may be different, in Jabalpur may be different, in different families it is different. Someone needs once a day, someone needs twice a day, someone may not eat at all, someone may not eat anything at all. So it has to be individualized, considering the glucose levels, considering the prior control. Some patients may not require any change in the therapy, and some patients may require drastic decrease in the therapy. And above all, I advise all my patients who are diabetic that even if you are keeping Roza for all the days, even if you are keeping Navratri fast, mind what you eat. Because there are certain very good things which are very helpful in diabetes, like kuttu. For example, I every day eat kuttu. I like the taste of it. And if you eat boiled kuttu, like khichdi of kuttu, it is very good. It controls your diabetes much better than other things. Avoid fried foods. So avoid those foods, avoid lot of potato. It is not that if you are in Navratri fasting, you have to eat potato. You can eat other things also, because there is sweet potato which would not increase glucose. So you have to make the right choices of everything that is there, that is just as in life. So you have to adapt to these new circumstances.
Thank you, Dr. Rajesh
Thank you,
Kesri.
Dr. Rajesh.
I request our chairpersons
Thank
to
you very
kindly join Dr. Rajesh Kesri on stage to present memento. Do we have Dr. Kanika Seth with us? Dr. Kanika is with us. Please kindly join on stage to present memento to our chairpersons. फोटोग्राफ के लिए सामने से अगर आप हट जाएंगे तो फोटो अच्छी आ जाएगी सर. A huge round of applause. That was indeed an enlightening talk by Dr. Rajesh. Quickly moving on to our next session, I would like to call upon for chairing Dr. Kanika, please kindly present memento to our chairpersons. For the next set of chairpersons, would like to invite on chair Dr. Sanjay Nema, Dr. Ranu Tiwari Mishra, Dr. Janki Punekar and Dr. Ajay Bhandari sir to kindly come and take their seats. Dr. Sanjay Nema, Dr. Ranu Tiwari Mishra, Dr. Janki Punekar and Dr. Ajay Bhandari. Our speaker for this session, Dr. Navneet Agrawal. I request our chairpersons to kindly introduce our speaker, Dr. Navneet Agrawal, to the conference.
Professor Navneet Agrawal is the Chief Diabetologist and Director, Diabetes, Obesity and Thyroid Center, Gwalior. And he is a visiting professor, Faculty of Medical Sciences, Vikrant University, Gwalior. He is visiting faculty, International Institute of Health Management Research, Delhi. Academic Director of MRCP UK at Link Hospital, Gwalior. Regional Faculty of Public Health Foundation of India for courses, many courses. Regional Faculty for IDF, National Diabetes Educator, Editor and Reviewer for various national and international journals. Published more than 120 papers in national and international journals. He has many awards to his credits. Now over to Dr. Navneet Sharma. He will speak on the glucose continuous monitoring system.
Thank you, sir. Thank you, sir. Thank you for the nice words. At the outset, I wish to thank the organizing committee, especially Dr. Bhardwaj sir and Dr. Ankit Seth for inviting me and giving an opportunity to discuss the role of CGMS in clinical considerations. In fact, I can say that as Dr. Kesri was discussing about the fasting and feasting in diabetes, and sir was asking that how to manage the hypo and hyperglycemia, I think my talk can be an answer for managing the hypo and hyper, particularly in the fasting, in any ways, but otherwise like with the fasting, because like we always fear the risk of hypoglycemia during fasting. And in fact, as sir was asking the guidelines about the fasting, so sir, for an answer, we have published a series of papers in IJEM, International Journal of Endocrinology and Metabolism, fasting and feasting in all breaths, like maybe Navratra, Roja and everything. So we have 4 or 5 publications on that. Anyways, coming back to my talk, we know that the India is a home to the more than 100 million people with diabetes, and that too, we have a relatively earlier onset of type 2 diabetes. We have a higher insulin resistance. We have a greater insulin secretory defect, and the worst part of our people with diabetes or the country is that we have an average higher A1C by 2%, and almost around 4/5 of the patients are not controlled, not achieving the target A1C. And because of that, almost 80% of the people are undiagnosed, and because of that, we have a high risk of micro and macrovascular complications, almost ranging from 14 to 30% of risk of retinopathy, nephropathy, neuropathy, any microvascular complication because of this level of the uncontrolled or the above the target diabetes. And we know this data that if the A1C is more than 7%, the risk of developing micro and macrovascular complication multiplies by almost more than 2 times. So there is a high risk of developing complication in our population. And so apart from the lack of compliance, adherence to treatment, there are multiple factors, but the major factor in uncontrolled diabetes in India is our dietary habits. Because we know the data from the multiple larger clinical trials, maybe like the STARS study, and there are multiple studies which have shown that almost around 65 to 70% of our calories, they come from the carbs. So because like we are the cereal based, we have the cereal based diet, we have a high carb diet. So that is a major challenge, because, and that is causing on to the beyond, like we are not achieving the targets. And we know that apart from the Caucasians and the Europeans, the contribution of the the fasting and PPG to the A1C or the raised A1C is equally even at the higher A1Cs as compared to the Western and Caucasian population. So the postprandial hyperglycemia, the high carb diet is also contributing the higher A1Cs. And another challenge is that we, as an Asians, as an Indians, we respond differently to the same carb. So maybe, and every person has a different response to the same carb, same amount of carb. So maybe the carb response or the glycemic excursion is different and ranging from one person to another. It is different from the Western and Caucasian. So like we have to see what is the carb response or the glycemic excursion to that particular carb. So for that, we need a frequent SMBG, but due to many reasons, SMBG is not practiced properly and adequately. Though all the international guidelines, they have highlighted the importance of SMBG. It should be done regularly. There are multiple guidelines that how frequently we should do in type 1, in type 2, patient on type 2 with insulin. So there are different guidelines, but I'm sure almost around only 7% of the population, there was a study which has shown only 7% of the population is doing SMBG as recommended. So there is a lack of SMBG. And it has been also 4-5% lower A1C as compared to the patient, those who are not doing a regular SMBG. But is only A1C, focusing on A1C sufficient? This is the graph from two patients who has the same A1C of 7%, but we can see in the patient A, there is a higher glycemic variability, whereas in patient B, it is in the time in range. So though the A1C is same, but there is a different in the glycemic variability. So like this A1C of 7 can have a different phases, like 40% high, 40% in range, or 20% low, even 70%, 100% range. But the outcome is different. Though the A1C is 7, but it's not only the A1C that we can focus on the A1C and will not have a complication. So the same A1C can show you the different, like the underlying what is going on, we never know. For that, we need to go for a continuous glucose monitoring, because like we know that the chronic hyperglycemia versus frequent acute hyperglycemic variability. Acute hyperglycemic variability is directly responsible for the endothelial dysfunction, and we know that the endothelial dysfunction is responsible for the macrovascular complications. So the journey from SMBG has shifted to the CGM, because like A1C almost every time doesn't tell us the whole story, and the utility of the A1C can be enhanced when we are combining it with the SMBG or the CGMS. So even the frequent testers, they often miss the significant glucose fluctuation. So the CGMS data can tell us about the glycemic variability. And in fact, like all the recommendation, be it IDEA, be it ADA, which has shown that the CGM can be redefining the diabetes health. It can be bringing the revolution in the glucose management or diabetes management. We all know that the CGMS has a sensor, which is and a transmitter. So like the receiver, like the CGMS transmitter, which is fixed on the arm, and it transmits the data to a receiver, which was initially a reader, but now it has been taken care by the mobile app. So all the smartphone apps or the smartphone mobile, and there are multiple apps which can now receive the data, so you don't need to have a reader, which we usually have in the second generation CGMS. And there is a CGM sensor which is inside the interstitial fluid. So the important thing which we need to understand while we are reading the data from the CGM, that it is in the interstitial fluid. There is a difference, we all know, from a venous plasma versus capillary blood glucose and the interstitial fluid. So there is a time lag of 3 to 10 minutes from this interstitial fluid to as compared to this capillary blood or the glucometer values. So there is a time lag between the interstitial fluid and the capillary blood glucose, because this sensor is in the interstitial fluid, not it is directly measuring from any blood, and they are converted into the capillary blood glucose well equivalent to. So like there is a development of the CGMS from ranging from the first generation to the second generation. Now we have a third generation, and almost the CGMS has shown multiple evolutions ranging from the initially, like if you see the accuracy, about the accuracy, and based on the data of the CGMS, now the different guidelines, maybe ADA or all the international guidelines, they have come that what should be target, the time in range. So in type 2 diabetes, at least it should be more than 70% for like pregnancy, and type 1 diabetes, we should target of more than 70% if the patient is young. Patient is like, we are targeting a higher or the tight glycemic control, we can achieve a more or the more than 70-80% time in range. So depending on the age, depending on the target, depending on the population, we should target our time in range. So and time above range and time below range, because like the time in range will tells us that how much frequent or how much will the incidence of the risk of complications. There is a relationship between time in range. So like if the time in range drops from 70 to 50%, the A1C, like when the time in range is 70%, the A1C is around 7. When time in range is around 50%, then the A1C is around 8. So there is a strong correlation between time in range and the A1C also. It's also like if the time in range improves, there is a risk of developing the complication also reduces. So if the time in range is improving, this is the data which has shown that the risk of complication of the like macrovascular complication, it reduced if the time in range improved. And if the time in range drops by 10%, the risk of retinopathy, risk of nephropathy, it increases by 40% or 64%. And not only the hyperglycemia, the CGMS can also help in managing the hypoglycemia, preventing the risk of complications of hyperglycemia. there are multiple publications or there are meta-analysis which have shown that the risk of hypoglycemia, particularly type 1 diabetes patients who are on insulin therapy or patients who are on the pump therapy, we can reduce the risk of hypoglycemia. But there are some clinical considerations or there are some practical considerations. Accuracy and reliability is always in our mind as a clinician, as a diabetologist, because like whenever the technology or new technology comes, like the wearables or any technology, there is always a challenge of the accuracy and the reliability. Then there are some sensor calibration and cost, of course, as of now, because like we are from the pocket mark in India, we have to purchase. So like first coming on the accuracy and the reliability. So like MARD, which is a mean absolute relative difference, is a parameter which has been taken or which is considered for the accuracy and the reliability of the CGMS system. And MARD is calculated on the basis of the reference values, or like reference if you are going from the capillary blood glucose, like some CGMS has done it compared to the capillary blood glucose, some has done from the venous. So depending on, so like this is a mean absolute relative difference, and this is being shown as a relative difference from the reference measurement device, and then it is being calculated with this help of this formula. And if you see from the generation 1, the MARD was 14.5, it has come down to 8.3. So now the recent sensors of the CGMS which is available, ranging from 8.1 to 8.6 or 8.9. So like different companies, the commercially available CGMS, they have the MARD of 8.1 to 8.6. Apart from that, CGMS accuracy also depends on the physiological and environmental factors, maybe like because like there the MARD, this increases in hypoglycemia when there is a rapid glucose excretion, when there is a physical exercise, strenuous physical exercise, sensor compression, like if the patient has fitted to the sensor on the arm and patient sleeps like this, then the sensor or the CGMS, any sensor can give erratic values, and early and late sensor wear. So like these are the known variable factors, not a device malfunction. Another important part is like a commonly, like we know that the MARD is a commonly used factor, and the same CGMS system has shown the different MARD in the different studies. Same, from the same company, it has shown the different MARD in the different studies. So this is again a problem statement. Same patient wearing 3 CGMS at the same time parallelly are showing different data. So the same patient, wearing 3 CGMS at the same time. This is the recent publication which has shown that there is a discordant in the CGM data. So, and this is the comprehensive review when this is the MARD during rest of all the CGMS which is available globally and internationally. And if you compare it with the during exercise, this MARD at the rest is hovering around 10 to 15, but when it comes to the exercise, this MARD goes to even 25 to 26 during exercise for almost all the CGMs available. So this, and also like during the hypoglycemia, again there are discordant values in the CGMS system. Another challenge is some medications like the acetaminophen, the vitamin C, which also gives higher values in some CGMS, even in generation 2 and generation 3. So patients who are taking more than 500 to 1000 milligram of ascorbic acid, or patients who are taking more than 1000 milligram of acetaminophen, again they interact with the sensors and they can give higher values. So to mitigate these all problems, some sensors, they say that we are the manufacturer, we are calibrated at the manufacturer level. Some sensors are available which can be calibrated later on to avoid these discordant. So this is the data which has shown that at the baseline the MARD was 25%, and when the repeated calibration was done, maybe at second day and third day, this MARD came down to 9.6 or 12.7. So like MARD can be improved, or the variability can be improved if there is a discordant in the data, can be improved with the calibration of the CGMS, which is possible in some commercially available CGMS system. Some other barriers, if you see, there are skin reactions with the CGMS, there are intermittent physical activity, concerns about this data accuracy, we already discussed. Some CGMS systems have alarms, so like sometimes they give a false alarms. Then you have a device operational issues, sensor related issues, or discomfort. But major challenge, or we can say the clinical consideration as a clinician, while we are using, like we should have the beyond technology, we should consider about the ethical consideration, because like it's sometimes the patient, those who are not even diabetes, they are using CGMS, they are overwhelmed with the response, they are overwhelmed with the data, and it is except like over medication. And then the patient autonomy abandoned, because like we know that this data is going to some other server, to some company server, so like about the safety of the data, the privacy and the data privacy, so data sharing, and we are not taking the informed consent. So again, like basically this data is going to some other server, so we have to consider that these ethical considerations while we are using the CGMS. And the cloud data vulnerabilities, third party sharing of the concern, there may be unauthorized access, like this data is sharing between the different say technology companies. So again we have to think about the unauthorized access and the cyber security flaws. Other changes, like the challenges with sensor failure, high upfront cost, because like it is a costly, but maybe with time we'll be having the reduction in the cost and the limited coverage and reimbursement, because like it is not being currently reimbursed. So for that, the International Federation of Clinical Laboratories, this has come out with the proposed guidelines to avoid the challenges, how to mitigate the challenges, that what should be study design, what should be the distribution comparative data, what should be the minimum accuracy for the CGMS, and what should be the characterization of the performance. Coming on to the future, yes, like CGM technology may continue to evolve beyond the wearable, or like it come to the wearable, non-contact, non-invasive, the the better wearability, improved accuracy, AI-driven decision support, and the lower cost. And goal is to broader access and more personalized glucose care. Thank you very much for the patience hearing.
Thank you very much, Dr. Navneet Agrawal, sir, for presenting the topic very nicely. If there is any question from the audience, he will be pleased to answer them.
We will not be taking any questions. I request our chairpersons to kindly join on stage with our speaker to present memento to our speaker. Sir, it was indeed a lucid presentation from you. Thank you so much. Do we have Dr. Akash Seth with us? Please join on stage, sir. A huge round of applause. That was Dr. Navneet Agrawal addressing the conference. I request Dr. Akash Seth to kindly present memento to our chairpersons. As the memento distribution is going on, I would like to invite to chair Dr. Akhilesh Gumasta, Dr. Abhay Srivastav, Dr. Ravi Arya, Dr. Shubham Jain. I again repeat, Dr. Akhilesh Gumasta, Dr. Abhay Srivastav, Dr. Ravi Arya, and Dr. Shubham Jain. To chair for the next session, our speaker, Dr. Manisha Singh. We welcome Dr. Manisha Singh on dais. I request our chairpersons to please introduce our speaker.
Dr. Manisha Singh is from Gwalior, and she will be presenting her paper on diabetic foot. Please.
Dr. Sameek Raza is there. Thank you, sir, for the intro, and thank you for having me here. My deep and sincere regards to Dr. Bhardwaj sir, Dr. Seth, and the members organizing committee for giving me the opportunity to speak on this problem of diabetic foot, which is one of the most frequent and serious complications. So the problem question today is that if you have a foot which looks like neuroischemic, but actually it is an infective thrombosis giving rise to a dusky forefoot and midfoot with a blister and a pus discharge and a black gangrenous little toe, and it was debrided as it presented in the emergency operation theater, and the toe was amputated, hoping that everything will be fine because the blood circulation was good. At night we could not do any invasive study for the angiography, and then finally today the question arises is that how this good looking foot with good intact pulsations and everything has become very infected and foul smelling, and to add to it the patient has hyperglycemia and he's still not practicing diet control. So to answer this today, we'll discussing the clinical approach to new diabetic foot ulcer and the choice of antibiotics for diabetic foot infections. We know that in an overcrowded OPD in primary health centers, the basic foot examination may be neglected, and moreover the India still lives in villages where there is a lot of illiteracy and patients walk barefoot due to socio-religious cultural practices, and the diabetic foot ulcers may be treated by any sort of homemade remedy, including the turmeric or the homemade poultice, and even the red ants or the maggots may be stewing out of the dirty dressings, and the patient may be walking even barefoot with the ulcers there. So it is a very common, frequently encountered complication which is very difficult and challenging to treat. And
the most chronically infected and the stalled ulcers with the superadded peripheral artery disease and diabetics add complexity, risk of infection, slow or non-healing ulcers, indication for hospitalization, amputation, and poor quality of life and increased mortality. So early initiation of treatment and recognition is very important for a new onset ulcer, and we can see that most of the ulcers, they can be, majority amputations resulting from the infected ulcers can be prevented if the DFUs are addressed timely and rightly by the antibiotics, by timely debridements. And for that, it is important that we identify and regularly inspect the at-risk feet, and which include the plantar fissure, dorsal calluses, crowded toes, blisters, presence of blisters, onychomycosis, intertrigo, which should not be neglected in the examination, and appropriate screening for this at regular intervals is required, with instructions not to walk barefoot and use the appropriate foot ulcer. So any foot ulcer which is presenting to us needs to undergo a structural integrated care process as well as the clinical care process. The structural integrated care process involves the foot risk categorization, prioritization, clearing of the referral pathways, and preventive and protective care, whereas the clinical care process involves multidisciplinary foot services, that is the MDFS, and new DFU referrals tries to be seen within 24 hours of presentation to the health system, which is mandatory to salvage the foot. And initial patient assessment or initial review needs history, examination, assessment, and a proper clinical workup. It's not moving. It's not moving. Presentation is not moving, please. Somebody to help. So initial assessment requires first DFU or past history, ulceration, or any vascular procedures if have been performed, or any surgeries performed on the foot, history of duration of diabetes, current control, smoking, comorbidity screening, and social isolation, etc. So first, for the vascular workup, we would like to examine the foot pulses, which is a basic thing, and absence of foot pulses does not indicate that the disease or the vascular disease is missing, which is so common in the diabetes as the infrageniculate or below knee disease, atherosclerosis, and calcification. So even if we have to see for the pulse quality, compare it bilaterally, and note the temperature and capillary refill as well. Also, the weak or absent femoral and the distal pulses indicates a more proximal disease, that is in the aortoiliac and the femoral level, compared to the normal femoral popliteal absent full pulses, which indicates a infrageniculate or the tibioperoneal disease, which is very common. And proximal, it's important because proximal disease you can treat with angioplasty or bypass, whereas tibial disease are very difficult to treat due to extensive calcification and the small caliber vessels. So not only the non-invasive tests are important, but also we should know where the advanced vascular imaging is needed. After taking the history and assessing for the history, which includes the claudication pain or the rest pain or the smoking, dyslipidemia, these kind of history, hypertension, stroke, and longer duration, we need to examine the patient with all footwear and socks removed in the physician's OPD and look for the signs of infections, web spaces, pressure points, etc. And pressure studies in the lower limb are needed. So we are mostly, all of us are doing ABI now, but in the diabetics, the ABI glyphs has less value because it may give falsely elevated levels due to calcification of the or the medial sclerosis of the vessels, and even in the presence of the significant PAD. So we are getting higher values, and low level values may have still lower pressures. So it is the waveform in the handheld Doppler which you used in the OPD which is important. So the monophasic waveform indicates severe arterial insufficiency and urgent referral for vascular imaging. And also, if ABI is not contributing, toe pressures are important because the metatarsal arteries are spared of calcification, and toe brachial index is important. So toe pressures less than 30 and toe brachial index less than 0.6 indicates ischemic disease and needs further evaluation. So we can see the segmental pressure studies are also being practiced by the vascular surgeon. TCPO2 is also done to see the perfusion to the ulcers, and less than 30, it indicates, when the value is less than 30, it indicates that it has a poor outcome, healing outcome. And advanced imaging indications may be non-healing ulcer, less than 50% healing in 4 to 6 weeks or 1 month time. Severe ABI less than 0.5 indicates urgent vascular reconsult and advanced imaging. Equivocal ABI, TBI, Doppler ultrasound test, and planning revascularization when ABIs are less than 0.4. This also needs entire lower extremity circulation evaluation and a complete cardiac evaluation in patient of PAD. It's also important to categorize them as ischemic, neuroischemic, and the neuropathic ulcer. Testing for large fiber neuropathy gives us the good information, but in places where equipment are not available, Ipswich test, that is a finger toe test, can be done, and 3 or 4 out of 5 absent sensation signifies presence of neuropathy without any equipment. Small fiber tests are more informative. Patient hardly reaches to us in this time, and the gold standard single test is punch skin biopsy, which the patient will not agree being invasive, minimally invasive. So the various pseudoscan or the neuropad or QSAR tests are done based on sweat secretion, and pseudoscan is very neuropad helps in triage because it gives us a very quick result with the litmus paper. And quantitative sensory testing, that is thermal perception threshold, it gives an idea of the small nerve fiber functions. So these are the various tests, and corneal confocal microscopy is also available. So assessment of motor neuropathy comes after sensory neuropathy, because there may be callus due to sensory neuropathy, there may be plantar fissures due to autonomic neuropathy, toe deformities and foot deformities, presence of hammer toe, intrinsic minus foot, and foot deformity in the form of or toe deformity in the form of valgus or varus deformity. There will be crowding of toes, which is seen in the diabetics with motor neuropathy. So now plantar pressure studies give us the areas of high pressure evaluation, and they are done usually with the help of the foot mat or the foot scan. Musculoskeletal assessment may be done to note the range of motion. Biomechanical tests, too many toe sign, calf muscles, circumference, etc. may be taken. Stemmer sign, in which you are unable to pinch the skin, and these may be done. Radio imaging assessment is very important because it helps us know any soft tissue or gas or presence of foreign body, infection from DFO or osteomyelitic foot. So MRI, X-ray and ankle, in the weight bearing position, X-rays of the foot and ankle should be taken. And if osteomyelitis helps in differentiating between the osteomyelitis can be seen different from soft tissue infection in the MRI, and if that is equivocal, then we go for the further SPECT CT or the ultrasound. So ultrasound may be helpful in the diagnostic aspiration or collection situations. You can see the various types of radiographs like Charcot foot with deformity, foreign body, osteomyelitis, gas in the necrotizing fasciitis, in the subcutaneous gas, and medial calcification of arteries, which is very nicely seen here. So advanced imaging studies may be required in certain situations when ABI is very less, as I told you, and interventional DSA CT angio may be required if there is block and long segment block. Endovascular therapy is preferred nowadays over the bypass surgery. Lab assessment, routine tests may be done. What I want to tell here is that CRP is very important, as it may rise in the acute infective position and remain sustained for 7 days time, which gives us enough time to control the infections. So DFU or the diabetic foot ulcer, location and number are important. Each ulcer to be described separately if there are multiple, and document the wound size and the depth, and classify the wound according to the Sindbad classification, which is based on the depth also. And this is considered to be best, and this is also used for the exchange between the health workers. Clinical signs of infection, any cardinal signs of inflammation which are present, 2 of them are present, cardinal signs, then also it indicates infection apart from the smell and the presence of a discharge. So you have to also not to miss cellulitis, which indicates the spread of the infection. So you can see the wound dimensions to be done. And here is the instrument illuminative. You can differentiate between the gram-positive and gram-negative bedside, depending on the fluorescence which is casted by the bacteria. So components of DFU control are multiple, wound and infection control being the main, apart from the vascular, mechanical, metabolic and education part. So we have to, as I said, identify DFI according to the IWGDF guidelines, depending upon the signs of inflammation. Foul odor, friable discolored tissue, undermining of wound edges indicates the secondary surrogate indicators of infection. And features of limb-threatening infection means if there are a lot of blisters present, necrosis and spreading cellulitis despite management, plus presence of systemic signs of infection, then it indicates that it is a limb-threatening infection, needs to be controlled imminently to ensure that it doesn't become become life-threatening. And deep tissue cultures, after cleaning the ulcer, debriding the ulcer, deep tissue culture samples are to be obtained in the form of soft tissue or the bone if there is suspicion of the probe to the bone test is positive. So we see mostly the spectrum as presence of wet or dry gangrene or presence of abscess, then intertrigo. You can see the various infected heel ulcers. So non-surgical offloading is the must. Offload the ulcer to prevent further necrosis and allow the ulcer to heal. So when the patient is having active ulcer, we just offload them in the temporary offloading braces or the small chappals which are specially, or sandals which are meant for offloading. But permanent footwear is given once the ulcer has healed. So pneumatic walker and the removable cast probe walkers, these are used for supporting the heel ulcer as well as for the Charcot foot. Surgical offloading done by various surgical procedures like osteotomy, arthroplasty, but of importance is this percutaneous flexor tenotomy. It's not clicking. Which can be done as a OPD procedure. This can be done with the help of a needle in the OPD, cutting the tendon through and through, and patient can be sent back home. Selective plantar fascia release, medial and lateral slip can be done so as to reduce the hammer toes and the claw toes. This is not moving again. The presentation is not moving. Can somebody help? Presentation is not moving. आगे नहीं बढ़ रहा है. उसको stop कर दीजिए, उस वाले को, last वाले वीडियो को. Okay. Next कर दीजिए. So patient education and foot care are very important to encourage self-management, daily foot care for the patient. And it helps in a long way to improve the reduction in the ulcer and amputation and improve the outcome. So new diabetic foot ulcer, when you comes to the OPD, neuropathy is present. If there is no infection, just do a debridement of the ulcer local bedside and give appropriate offloading support and medical care. When there is presence of infection or cellulitis, you have to do a sharp debridement and take active measures for infection control in the form of injectable and the oral antibiotics, apart from supportive measures. With underlying osteomyelitis, you have to do a bone, maybe small intra-foot amputations are preferable compared to the more proximal below near the this thing. So you have to act early, and if the ischemia is present, not known to be critical, then you can go for a neuropathic just in the same way as ulcer, non-infected ulcer. If there is CLI, go for a revascularization. So if the healing is predicted in neuropathic, you have to we have done whatever we have said. So if the healing is not going on, it's healing slowly, more than 4 to 6 weeks, then you have to ensure proper footwear, proper vascular surveillance, and if needed, revascularization like angioplasty or bypass or endovascular therapy measures, and close supervision of the patient. And in the patients with only peripheral arterial disease, then we have to move then ischemic and then non-ischemic with advanced imaging and the needed revascularization. So invasion, multiplication of pathogenic organisms within the body tissue of the diabetic, for the wound to get infected, it goes to depends upon the diversity of the microbes, synergistic association of the microbial species, microbial load more than 10 to the power 5, and existence of infective organism. So when the count is higher, then what we have to do is that we have to take active measures to control the infections. So MRSA prevalence is very high in our country because of the low income settings, and we have the Staph aureus as even though in the polymicrobial diabetic foot infection, Staph aureus is the main organism, but in India, gram-negative rods and this enterococcus and also the anaerobes MRSA proportion is higher compared to the gram-positive population. So Pseudomonas and MRSA therapy is done if the risk factors are present. So all guidelines show that antibiotic therapy is not a standard solution, and we have to give proper wound care, offloading and surgical intervention as well. We have to categorize according to the ITSA classification, mild, moderate, severe, depending upon the presence of systemic signs and spread of infection. Diabetic foot wounds are stalled in the sense that excess inflammation is there, necrotic tissue with biofilm is there, and this delays wound healing, difficult to swallow infection, and Surgical debridement is essential according to the guidelines, and our regular wound inspection is essential after debridement and avoided in the ischemic patients. And surgical debridement for diabetic foot wounds may be sharp surgical, which is the best, timely and aggressive radical wound debridement. There may be other methods like curettage, ultrasound debridement, autolytic or enzymatic, which are less in use now. So IWGDF guidelines suggest that we should not use systemic or local antibiotics for uninfected ulcer and obtain deep tissue samples only after debridement. Consider early surgery with antibiotics, and if the bone is left alone with evidence of osteomyelitis but without any treatment, then we should start with the higher antibiotics for a longer duration. So uninfected wound should not be cultured. Deep tissue cultures, avoiding swab cultures and bone biopsy of the exposed bone if you suspect the probe to bone test is positive. So the common antibiotics you all know being physicians, which are used in your OPD, and newly approved antibiotics have come up like ceftaroline, delafloxacin, omadacycline, tedizolid, etc. And empiric initial therapy we should use. It should cover all the, it should target the staph and strep mildly in the mild infections. If the infection severity is more, we should cover the gram negatives and the anaerobes. And then we should narrow down after the culture reports to the definitive or the selected or the targeted therapy. And clinically infected ulcers should not be treated with the antibiotics to support the antimicrobial resistance. So, again, we move forward that DFI regime logic is in mild infections, we give amoxiclav, ceflexin, clindamycin, and doxycycline. Moderate to severe gram-negative anaerobe targeted, we use piperacillin, tazobactam complex, or the ceftriaxone, metronidazole, or ertapenem. Tigecycline use is not recommended by IWGDF, and MRSA agent, if risk factors for MRSA are present like previous exposure or long treatment, history of hospitalization, then multi-drug resistant cases we go for the newer antibiotics like and which are targeting the pseudomonas, and we can use ceftazidime, avibactam combination in the form of they are used very commonly, imipenem, relibactam. These are more used, or the moxifloxacin and verobactam. These are mostly cefdorocol is used when MBL is suspected, and empirical treatment should not be started for Pseudomonas aeruginosa unless risk factors are present. So we have to start on, for moderate to severe infection, start IV 4-5 days, then follow it on with the oral antibiotics. And extensive infections, low resolution, severe PID, we give antibiotics for at least 4 weeks or even 6 weeks. And for bones which are left behind not treated or treated on conservative, we give 6 weeks without amputation, or 3 weeks if the minor amputation has been performed. So again, local antibiotics are not so preferable, and there is no superiority over the local treatments to the systemic antibiotics. Similarly, topical antibacterial use have low level of evidence. So for MSSA, we use beta-lactams, which are superior than vancomycin pharmacodynamically. For MRSA, linezolid is better, but now we have come to the tedizolid, which is unfortunately being overused and recommended, and that is because of its shorter duration. But first therapy should be linezolid oral on the OPD basis, followed by vancomycin. Then if it doesn't respond, we should go for the tedizolid, otherwise we'll get resistance. So then ceftaroline is strong in a hospital MRSA option. Dalbavancin, these are in the experimental stage. Dalbavancin and odravancin, they are more for the gram positive. And clindamycin, delifloxacin, which can be used for the pseudomonas infection in the gram. So most of the newer antibiotics are targeted to the gram-negative organisms and for the resistant organisms. Tight glycemic control, good HbA1c, day-to-day basis is essential. Choose insulin whenever the wounds are deeper than the subcutaneous tissue or the large wounds, or you're expecting a PAD. Then wound dressings, and there is no single tailor-made dressing for all the wounds. And you should never use harsh chemicals like betadine, Savlon, and hydrogen, because these solutions, so I'm using Milsep spray and normal saline as the best cleansing solutions, and because these harsh chemicals may damage the further non-enzymatically damaged tissues. So we should use for necrotic wounds. We can, as I said, running short of time, we have various options. 6,000 plus products are available in the market. And here are the case scenarios. I will just take 2-3 minutes to rush through these important ones, which are the cases which are and showing the healed and how they have to be applied. So callus ulcer after shaying, reduce the 29 to 30 kilopascals pressure on that area, and then you can use a offloading, which I've used in the OPD. I use a front offload by a Samadhan technique. And post onychomycosis pericornea, I have to remove the nail and start on the antifungals, topical as well as the oral antifungals. And forefoot plantar abscess occurs on the walking surface. You have not to make the mistake of just giving a single incision. Explore all the open spaces below the metatarsal heads, and you have seen the wound healing. And intertrigo, it's again important to offload all these, otherwise you will not get the result. Intertrigo or the web space infection, you can see how extensive is the exploration, and it may be combined with the toe amputation as well. Venous gangrene, they always need offloading in the form of venous 4-layer bandage application may be done in the gutters area, and the patient have a restricted walk in the daytime. Necrotizing fasciitis needs ICU care, early debridement, second look at even redebridement, and a fasciotomy. Then chronic Charcot foot, this was a case where over a chronic burnt out Charcot foot, there was a glass piece injury. Patient came 1 year later, and again I had to do an ostectomy because the bones had fused without any proper alignment. Then the patient healed completely. And active Charcot, as you know, it looks like an inflamed foot, but the WBC and all are normal in that. Ischemic DFU, this was my patient, he was an engineer from Qatar, and he had dropped some hot water on his feet, hidden the history of diabetes, hypertension and smoking, and then third day it incurred that I removed the blisters and I found all the toes were black. The patient had no CLI, meaning all the vessels below were occluded, they were corkscrew collaterals, nothing was possible, no angioplasty or any endovascular therapy. Bypass, he was not ready. Slowly I removed few of the toes, and you can see the last picture where the patient was given a footwear, and he's working nicely at Qatar now. So you have to do a complete revascularization, which is very complete revascularization, complete evaluation of the foot, not take anything for granted, because the patient told me, and I didn't even palpate the foot pulses in this patient. Now, another is excessive use of NPWT. There are indications it should better be avoided in the ischemic and highly infected ulcers. Otherwise, it gives very good results, as seen in this case. Even over the graft, we put the to get the granulations, we do the VAC, and post graft also we can put the VAC. PRP sessions, you can see the very good results, and the heel ulcer which are difficult to heal, healing with the PRP session. Even with the second session itself, we start getting good result. Topical oxygen ozone therapy, which are very widely used, they can be used as an adjunct procedure, and you can see the increased number of Osing points, just last only. So here again, we have used a combination of the various things, followed by revascularization and HBOT or the hyperbaric oxygen, which has other barotrauma and other pneumothorax-like complications, less safe, but gives very good results in recalcitrant osteomyelitis cases. So these are the published cases where you can, looking at the cases, you can see how these wounds healed without any grafting also. It was an infected foot, transmetatarsal amputation, and a healed ulcer with a dorsal rotation flap. Another is something which I thought will never heal, is a childhood injury, shortening of the foot, and the patient had complete healing with the normal solutions and normal saline treatings. So another case. So now let us come to the summary. All diabetics must undergo comprehensive annual foot evaluation, or as and when indicated, to identify risk factors. At risk feet must be prioritized. Infected cases must be prioritized by MDRS team. Community food service must work in close liaison with PSC. New food DFU must be seen within 24 hours. Well-designed referral pathways should be there. Any blockages in the referral pathways must be cleared by the structural processes. Regular audit and assessment of the pathways are essential. And antibiotic stewardship is very important to narrow the effective empirical, to find out the narrowest effective regimen and prevent antimicrobial resistance. MDS approach or the multidisciplinary approach is mandatory. It helps give very good outcome, you can see. And so again, now answer to the question problem, which I put in the first thing, is a highly infected foot where we have not followed the proper protocols. The patient was treated at different levels in the PSC or at where all these protocols. So it is important to educate our healthcare staff and the nursing staff to evaluate the patient properly and know about this, how to manage the diabetic foot. Thank you for the patient
Thank you,
hearing.
madam. Thank you, Dr. Manisha Singh ji. Actually, we should have a separate conference on diabetic foot. Yes, it needs, and because we are orthopedic surgeons, so we were very interested in this. So I did not ask her to that your time out is there because diabetic foot has no time out. Thank you, madam.
Thank you so much, sir.
Thank you so much, ma'am. That was a lucid presentation. I request our chairpersons to kindly come on stage to present memento to our speaker. Do we have Dr. Riti Seth with us? Riti ma'am, are you there? Please come on stage. A huge round of applause. It was indeed a very, very well presented talk. I request Dr. Riti Seth to present memento to our chairpersons. With this, we will be proceeding with our inaugural ceremony. Requesting all the delegates to kindly maintain silence, we will be starting off with our inaugural ceremony in a few minutes. Now, to formally mark this conference, we proceed towards the inaugural ceremony. I request our organizing chairpersons, Dr. V.K. Bharadwaj, and organizing secretary, Dr. Ankit Seth, to kindly accompany our guests on stage. Dr. Bharadwaj and Dr. Ankit Seth to kindly accompany our guests on stage, our chief guest, Brigadier Dr. Nikhat Jahan for Madhya Bharat area. She is the professor and consultant anesthesia and critical care medicine. Our guest of honor, Dr. Navneet Saxena, Dean, NSCB Medical College, Jabalpur. Our special guest, Dr. Sanjay Mishra, Joint Director and CMHO, Jabalpur. Our special guest, Dr. Richa Sharma, President, IMA, Jabalpur, and Deputy Medical Superintendent, NSCB Medical College, Jabalpur. Our distinguished speaker and National President, RSSDI, Dr. Sunil Gupta, sir. Our special guest, Dr. Tapas Chakma, ex-scientist from NIRTH, ICMR, Jabalpur. Dr. Yatish Jain, Vishuddh Healthcare Jan Seva Samiti Sachiv. I request all the dignitaries to kindly come forward for the lamp lighting ceremony. Riti ma'am, kindly join. Requesting our guests to kindly come forward for the lamp lighting ceremony. Not all lamps burn with fire. Some illuminate with wisdom. Lamp lighting, a symbolic moment to signify dispelling of darkness and igniting of thought and enlightenment.
शुक्लां ब्रह्म विचार सार परमां आद्यां जगद्व्यापिनीं वीणा पुस्तकधारिणीमभयदां जाड्यान्धकारापहा
On behalf of the organizing committee, I would like to say that we are honored and very happy to have the dignitaries with us today. Kindly take your seat. As we proceed towards the floral welcome of our guests, I request our organizing chairperson, Dr. V. Bharadwaj, to give a warm floral welcome to our chief guest, Brigadier Dr. Nikhat Jahan ma'am. Dr. Bharadwaj sir to welcome our chief guest, Brigadier Dr. Nikhat Jahan ma'am. A huge round of applause. I request our organizing secretary, Dr. Ankit Seth, to welcome our guest of honor, Dr. Navneet Saxena. Dr. Berani to welcome our special guest, Dr. Richa Sharma. Dr. Berani, please welcome our special guest, Dr. Richa Sharma. I request Professor Ritu Gupta to welcome Dr. Sanjay Mishra sir. Professor Ritu. Nalini Singhai ma'am is there. Dr. Nalini Singhai, please kindly welcome Dr. Sanjay Mishra sir. I request Dr. Kusum Jain ma'am to kindly come here. Dr. Kusum Jain ma'am to welcome our guest, Dr. Tapas Chakma sir. I request Dr. Akash Seth to welcome MPMC observer Dr. Deepak Vadkare. Dr. Akash Seth to welcome Dr. Vadkare. I request Dr. Ankit Seth, our organizing secretary, to welcome Dr. Sunil Gupta Seth. Photographs, they mark a special occasion and memories in our lives. I request Dr. Ankit Seth, our organizing secretary, to welcome Dr. Sunil Gupta sir. I request huge round of applause for this felicitation ceremony for Dr. Sunil. It's an honor to have you here, sir. I request our dignitaries to kindly take their seats on stage. I request Dr. Bharadwaj sir to kindly come on the dais for the welcome address.
questions which are instructive for the speakers as well. So CMEs are meant to be a bidirectional affair. It tends to enrich
Thank you so much. Now I would like to call upon the guys, our chief guest, Dr. Brigadier Nikhat Jahan. Please address the conference. We all are eagerly waiting to listen from you.
Respected Dr. Navneet, Nisha, Dr. Sunil, the dignitaries in the dais, all the dignitaries in the audience. I don't claim to be an expert on diabetes. I'm very honored to be here. I'm an anesthesiologist. So it's not that I'm untouched from diabetes. As an anesthetist, I don't know, all of you, you're mostly physicians here. I'm sure you've got a lot of referrals from the PA checkup clinics for patients who require surgery because they have poor glycemic control or they have autonomic instability. So diabetes touches all of us, and as an anesthetist and intensivist, I will be dealing with it intra-op, and what bothers us a lot is not just the glycemic control but the autonomic instability, which causes a lot of hemodynamic instability. Also in the ICU, glycemic control is one of the most important things. The fast harmonic, G stands for glycemic control. And there have been so many studies on glycemic control. The Vandenberg study which first said that you should do a tight glucose control. The same group then did the study and said not so tight control because there is so much hypoglycemia was not an expert on diabetes. For this conference, I can speak to my endocrinologist friends and I like to get some knowledge about those things. And they did the emerging trends in diabetes management. Also, sir, as a committee, I'm sure we have a lot of things to talk about what is linked in diabetes, where the things are headed. But even the FDA says now that it's not just glycemic control. You look at the cardiovascular and metabolic parameters also. Even the drugs, when drugs are becoming done, the companies are supposed to focus on this aspect, that there should not be any detrimental effect on the heart, on the kidney, and on the metabolism. Obesity is such a big risk factor, nutrition, exercise. And now we are looking at diabetes in a more holistic way, because it is emerging as such a big problem for all specialists. Everybody deal with diabetes. When I was preparing to speak to people here, I was looking at the history of diabetes, and what interested me most was not to look forward, all of us in today, but I just want to take you through the concepts. And there are so many lessons in the discovery of insulin. We all know that before 1920, diabetes was a diagnosis of die of diabetes, or insulin-dependent diabetes. Diabetes or type 2 diabetes is now emerging, of course, as the biggest problem. But people who are insulin-dependent diabetes still die. Children especially still die. And there was a search for solutions for finding treatment for diabetes. And all of us know who discovered insulin. Any of the younger specialists, who discovered insulin? Okay, Banting and Best. But who got the Nobel Prize for insulin? It was Banting and Macleod. So, there was so, when I was reading about insulin from various sources, it is so interesting. Once all the people who were trying to, there were many people. This was in University of Toronto, there were teams in London, there were teams in Europe, and they were trying to discover treatment for insulin. They were
it was not best. And initially, Franklin Benjamin, sorry, the first person, he said, I will give this award. He initially refused the Nobel Prize for discovering insulin because it was such a groundbreaking thing, and diabetes was such a common disease with no cure, and now here we have insulin. So it was a sensation. And he initially refused the prize because he said it is not required for best who should have got. This is professional integrity. This is integrity in research. All of us have to learn. Because as Indians, we have bad reputation in the international circles. All of us must have tried publishing in international journals without a reason or articles. As a whole, they think Indian articles are bad. So integrity is something we must learn from. One is resilience. So this is all the lessons coming out of the discovery of insulin. Second is professional integrity or research integrity. So he said because best work on it, he should have got it. But later he accepted the Nobel Prize and he shared the prize money with his medical student best who was only 22-year-old has discovered insulin along with Franklin, which is an amazing thing. So McLeod also in life said, I will share my prize with Cochrane. And he shared the prize with Cochrane. So only two people got it, but they shared it with the other two who contributed. This is an excellent example of how we should treat our colleagues. All of us at workplace face stress from our colleagues' behavior, from our own behavior, maybe they face problems, but yes, at work, this kind of thing, your friend has contributed to something that you must be given to that person. So after the discovery and the third point we learned from them is resilience. And never to get disappointed with the failure. You don't want the failure. When the first time Mr. King extract the insulin was the first patient who was working in the cancer, he developed an answer, and because of that infection he got worse. He said, no, stop it here, this doesn't work. But it did not happen. They purified it, and then the second injection was given, and something improved dramatically. He lived another 13 years with this insulin, and he died at the age of 27 with pneumonia. The second patient was the lady who was daughter of a very senior official in London, and she lived, she married, she had 3 children, and died at the age of 74 of a heart attack, not of diabetes. So resilience is one thing. Giving credit where it's due. But the best lesson, and here I want the pharma industry people who are here to please listen to what I'm saying next. After insulin came out, it was a groundbreaking thing. Patented. And anything patented, it was patented. But anybody know the cost of that patent? The cost of that patent was a nominal $1. Because they wanted this treatment, it was good for humanity, the potential to save millions of lives over the next few years. They did not make it a commercial thing. It was $1 patent. So that even the poorest of the poor could afford insulin. So this is an amazing thing because I really admire Dr. Devi Shetty and his vision for healthcare for the poor. And he always says, if it's not affordable, it is not treatment. And we as Indians have so many people who can't afford treatment. I'm very lucky and blessed, I say, and a lot of people here who are in the medical college, that we don't get money when we treat a patient. We give the patient treatment and the treatment is free for them. Not just that we don't get our salaries, but treatment is free to our patients. So if a person needs a treatment and we prescribe it, we get it. But if you at a private sector where a person doesn't have access to public health care,
don't look at the cost, but here doctors also should look at the patient, what he can afford, and prescribe accordingly. My endocrinologist friend says, you look at the patient's disease. What does he have? Comorbidities. Does he have a heart issue? Is he obese? Has he got a renal problem? And then you customize the treatment for that particular patient. And always use a combination of drugs. Don't just start with metformin. I said you should always look at those patients who mentioned status also if you are prescribing where best to try the patient. Because this is an extremely important part. We have everything available in India, whatever is available in the world. Today we have it available, but it has to be affordable to most of our people. I can't say that, yes, companies spend money on discovery of the drug, on research on that drug, they have to recover that money. But they should not recover that money very over. And this drug, osimertinib, which is extremely expensive, 10,500 rupees a tablet after discount to the government hospital. This drug, the patent is alive till 2024. So till 2024, the company can sell it at any price. And there have been so many molecules, they have spent so much money on that they need to cover. And today, every gun starts in the moment of gas and diabetes, again, cancer patients are diabetes very long, and they need this treatment right now. And today, I'm sure there will be a lot of deliberations. I'll move away from diabetes, and I just want to share a few things that we are the preventers as doctors. We don't look after ourselves, we all look after our patients. We don't take care of ourselves, so I want that all of you must take care of yourself and your families also. It's my time to do that. I'm going to say this now because I also come in contact with diabetes, so those are the things that I'm not taking care of my health or my something for them, and then there's no way you can do it. So while your parents are still there, please look after them, take care of them, because they have made us who we are, and that's why we're all sitting here today. Please take care of your parents and be good to your colleagues, because we want them to be good to us. So the first thing is to be the change that you want to see in the world, be good to your colleagues, and we should just be a community of community as well as Thank you so much. That was Vigna with us. I request Dr. Navneet Saxena to kindly come on the dais to address our conference.
that diabetes can be controlled by a single dose. I mean, let's say paracetamol, go for, take medicine and fever go off. And as a matter of fact, there are so many myths in the society that this diabetes is controlled only by exercise, this diabetes is controlled only by diet and exercise. So why should I take insulin? Why should I take insulin? So stop insulin. There are a lot of treatment should be affordable. Then it is people not suffer of pain, as you all know, we are all dying. Initially. So there is very common incidence everything is there. So, and then of course, the society has become more vigilant as far as all these concerns, because if that is not controlled properly, then it might be life is also. So, we are really thankful to this disease. We should Jan Seva Samiti has called me to speak to some experience with me, share with you and all the delegates. Please enjoy the sessions and enjoy the city as well. Thank you.
Thank you, sir. Now I request Dr. Sanjay Mishra sir to kindly come on the dais to address the conference.
वैसे ये कहना चाह रहा हूँ कि गवर्नमेंट सेक्टर अब उन्होंने नाम स्टार्ट जिसमें हम लोग स्क्रीनिंग के साथ साथ ये सब उपलब्ध करा रहे हैं। अभी हम लोगों ने डिजाइन डायबिटीज के ऊपर प्रोग्राम स्टार्ट किया जिसमें हम लोग कम्युनिकेबल डिजीज़ का प्रोग्राम है। इसमें हम लोगों को स्क्रीनिंग के बारे में बड़ी गंभीरता से हम लोग देख रहे हैं और हमको सबसे बड़ी दिक्कत हमारे अर्बन एरियाज से जा रही है, क्योंकि अर्बन एरियाज में हमारे प्राइवेट डॉक्टर्स बहुत हैं, हॉस्पिटल्स बहुत हैं, आंकड़े हमको नहीं मिल पा रहे हैं। हम लोग बार बार इस बारे में लिख रहे हैं, एसोसिएशन को भी लिख रहे हैं कि आप लोग अपनी क्लिनिक में जो भी पेशेंट्स देखते हैं हाइपरटेंशन और डायबिटीज़, एनसीडी में हमारे ये 2 और तीसरा कैंसर, खासकर हाइपरटेंशन और डायबिटीज़ के आंकड़े हम लोग आपसे चाह रहे हैं कि आप हमें वो आंकड़े दें जिससे कम से कम नेशनल लेवल पे और शासन को ये पता लग सके कि किस क्षेत्र में कितने ऐसे मरीज हैं, हम कैसे उनकी आंकड़े मांगेंगे कि कितने आपके हाइपरटेंसिव पेशेंट्स आपको मिले हैं, कितने आपको डायबिटीज मिले हैं, इससे हम अपने यहाँ और उसमें से जैसा मैडम ने भी बताया कि बहुत से गरीब मरीज हैं जो इलाज नहीं करा पाते, तो शासन अपनी तरफ से पूरा प्रयास कर रहा है, लेकिन जैसा आप सभी जानते हैं कि हम लोगों के ऊपर एक स्टैंप लगा होता है कि ये गवर्नमेंट के लोग या गवर्नमेंट हॉस्पिटल है तो यहाँ अच्छे से काम नहीं होता है। मैं आपको विश्वास करता हूँ कि आप सभी गवर्नमेंट बहुत सुधर चुकी है, तो जो भी गरीब मरीज हैं, प्लीज आपसे रिक्वेस्ट है कि आप और जो आंकड़े की मैंने बात की ये कॉन्फ्रेंस के लिए मैं विश्व ग्रुप को बहुत बहुत बधाई देता हूँ, शुभकामनाएं देता हूँ कि ऐसी कॉन्फ्रेंसेस कराते रहेंगे आगे भी, जिससे आपस में चर्चा के द्वारा हम अपने नॉलेज को बढ़ा सकते हैं। आप सभी को बहुत बहुत धन्यवाद सर।
Thank you so much, sir. We have Dr. Richa Sharma with us. Ma'am, I request you to kindly address the conference.
नमस्कार आदरणीय ब्रिगेडियर डॉक्टर निखत जहाँ मैडम, डॉक्टर नवनीत सक्सेना सर, संजय मिश्रा सर, डॉक्टर सुनील गुप्ता, डॉक्टर चकमा सर, डॉक्टर भारद्वाज सर, डॉक्टर अंकित सेठ, सभागार में उपस्थित सभी वरिष्ठ चिकित्सकगण व फार्मा बंधु, डॉक्टर रीति सेठ एंड एवरीवन एल्स प्रेजेंट ओवर हियर। आज की इस कॉन्फ्रेंस जो इमर्जिंग ट्रेंड इन डायबिटीज़ विशुद्ध हेल्थ केयर जनसेवा समिति डॉक्टर भारद्वाज सर के सहयोग से जो आयोजित की गई है, ये बहुत ही समसामयिक है। आज के समय में डायबिटीज़ का हम हर एज ग्रुप में देख रहे हैं, और जो इसकी थीम है डायबिटीज़ अक्रॉस द लाइफ स्पैन, इट इज़ वेरी इंपॉर्टेंट। और आज का ये जो सेशन है आपका 9 to 5:30 का, इसमें सभी एज ग्रुप में डायबिटीज़ को कवर करने का प्रयास किया जाएगा। अभी मैंने भी 1-2 टॉक सुनी थी, दे वर वंडरफुल, और मैं उम्मीद करती हूँ आगे के सेशंस भी बहुत अच्छे होंगे, एनलाइटनिंग होंगे और सभी को कवर करेंगे। IMA जबलपुर परिवार की ओर से मैं इस कॉन्फ्रेंस को आयोजन करताओं को बहुत बहुत बधाई देती हूँ, मुझे आमंत्रित करने के लिए बहुत धन्यवाद देती हूँ। और आप सबको अभी IMA जबलपुर के द्वारा अगले महीने में आयोजित की जाने वाली एथिक्स कॉन 21 and 22 फरवरी के लिए आमंत्रित करती हूँ। वो भी एक हमारी बहुत अच्छी कॉन्फ्रेंस होने वाली है, एथिकल प्रैक्टिस इन ऑल द स्पेशलिटीज़। सो आई इनवाइट यू ऑल टू प्लीज़ participate in that also. Thank you very much.
Thank you so much, ma'am. We have Dr. Tapas Chakma with us. I request Dr. Tapas to kindly come on the dais and address our conference. Over to you, sir.
First of all, I thank the organizers for giving me this opportunity to come and talk here. All the dignitaries in the dais and of the dais. Everybody knows the diabetes, the India is going to be the next diabetes hub and blah, 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 many things. What we are focusing, we have wonderful drugs now for controlling diabetes. Everybody is focusing on the individual managements. Yes, right from long-acting insulin and many, many oral hypoglycemics, but what we are probably forgotten and not being focused is the dietary factors. All our textbooks still says that the diabetes and its obesity relationship, overweight, all the physicians, did you come across the low BMI diabetics here? I'm sure you have. You go to the rural area, the 15% of the diabetics, the BMI is less than 18. What do we have with them? What do we have to treat them? Extremely difficult to treat whose BMI is less than 17, 35, 36 kg body weight. You can't give them metformin, you can't give them many things. Insulin not available in the rural area. Please do think of it, how we can treat this particular group. As it is going, what I feel and I hypothesize, I have written a number of articles, I have written in Current Science, I have written in Lancet, regarding this, the role of micronutrients. Micronutrients have disappeared from our food palette. And what micronutrients which are being promoted is in the form of biscuit with added sugar. The micronutrient has got no role. And the millets, which are supposed to be a zero glycemic index, are available in the supermarket as a superfood, which used to be our rural areas' main supplements or main this thing of our micronutrients. Yes, it is important to treat them, address them. Of course, probably if we think of it comprehensively, look into their micronutrient profile, I think you can have a better control and better this thing. The food pattern which has been changed over the last 3 decades, which I can see in my public health practice, how the crop pattern has changed, how the public distribution system has improved, so-called improved with only on carbohydrate and carbohydrate and carbohydrate, and no millets at all. So my request to all of you, please look into it for a comprehensive management and preventive aspect, also apart from the individual patients and their concepts. Wonderful presentations with a lot of diabetic control, and I'm sure these are also essential and required. And I wish the organizers a great success, and I wish all of the participants to enjoy this academic feast. Do think of it about the dietary aspect and the micronutrient aspect of in the non-communicable diseases, which we have probably forgotten. Thank you very much.
Thank you so much, sir. As we are approaching the end of the inaugural ceremony, there are 3 more felicitations to be done. I would like to call upon Dr. Lata Paryani ma'am to kindly come and facilitate Dr. Rakhi Bajpai and Dr. Komal Jain. A huge round of applause. With this, I would like to call upon Dr. Professor Manoj Indulkar sir to kindly join on stage. Dr. Indulkar sir is with us. Please come join on stage to felicitate Dr. Pallavi Londe ma'am. Pallavi ma'am. Clappings, please. Pallavi ma'am is the president of Jabalpur Pediatrics Association. A huge round of applause. Now I request Dr. Ankit Seth sir to kindly come on the dais for the vote of thanks for this inaugural ceremony and conference.
Good afternoon, respected dignitaries on the dais, distinguished guests, esteemed faculty member, dear colleagues and friends. At the conclusion of this August inaugural session of Diabetes Across Lifespan, it's my honor and privilege on the behalf of our organizing committee to propose a ceremonial vote of thanks. At the very outset, I humbly acknowledge and express our gratitude to the Almighty for His blessing, which have enabled us to come together today for this meaningful academic endeavor. I extend my deepest sense of gratitude to our chief guest, the Honorable Brigadier Nikhat Jahan Madam, for gracing this occasion with her esteemed presence. Madam, your visionary and inspiring address has set a lofty tone for the academic deliberation of this conference. We sincerely thankful to our special guest, Dr. Navneet Saxena sir, Dean Netaji Subhash Chandra Bose Medical College, Jabalpur, for his constant encouragement, institutional support and valuable guidance which have been instrumental in the organization of this event. We are truly honored by the presence of our guest of honor, Dr. Sanjay Mishra sir, Joint Director and Chief Medical Health Officer, Jabalpur, and Dr. Richa Sharma Madam, President, Indian Medical Association, and Dr. Tapas Chakma sir, retired scientist G from ICMR. Your unwavering commitment to public health and medical service continues to inspire the entire medical fraternity. A very special word of appreciation is reserved for our keynote speaker, Dr. Sunil Gupta, National President, RSDI. Sir, we are deeply grateful for your enlightening keynote address and sharing for your vast clinical wisdom and insight with us. My heartfelt appreciation also goes to our organizing chairman, Dr. Brind Bhardwaj sir, for his exemplary leadership and foresight, as well as to the patron and advisory committee for their steadfast support and guidance. I would like to place on record a sincere appreciation of scientific committee, particularly Dr. Parivan Swami sir, Dr. Ritu Gupta madam, Dr. Manoj Indukar sir, and Dr. Riti Jain Seth, whose academic leadership, scholarly vision, and meticulously planning have ensured a scientific program of this highest standard. Finally, I extend my heartfelt thanks to all our esteemed faculty members for their invaluable guidance, knowledge sharing, and unwavering support throughout this conference. I also like opportunity to acknowledge the delightful, dedicated effort of our Samiti Sachiv, Dr. Yatish Jain, our treasurer, Dr. Kanika Seth, and our executive member, Dr. Akash Seth, and Mr. Sanket Malaya, whose commitment and coordination have contributed significantly to the smooth conduct of this conference. Finally, I extend my sincere thanks to all our hosting partners, Jabalpur Endocrine Society, Indian Medical Association, Jabalpur Obs Gynae Society, MAHI, our sponsors and delegates, whose presence and active participation lend true purpose and meaningful this academic feast. Thank you, thanks a lot.
Thank you so much, sir. As we are concluding the inaugural ceremony, I request all the delegates to come downstage and followed with the keynote address and the scientific session for Dr. Sunil Gupta. I request Dr. Sunil Gupta to kindly come on the dais. Audio-visual team to kindly assist Dr. Gupta.
Should I start with the, yeah. So good morning everyone, and respected our chief guest, madam, all our other guests who were there at the time of inauguration. Before I forget, let me convey my profuse thanks to Dr. Bhardwaj, Dr. Ankit for this felicitation, and the whole Madhya Pradesh, including Jabalpur, for your overwhelming support in the election we had a few months back. And I'll remember this throughout my life, because that was very positive and very proactive behavior from this part of the country. I belong to some part of Madhya Pradesh. My father was a student of Jabalpur college, and he was co-faculty with Bhagwan Ranjesh ji when he was here in the college. And then, yeah. So, and then we were from Balaghat district, and I had my primary education. So partially I am from Madhya Pradesh, so I am staying in Maharashtra. And my roots are again from Betul district. So Betul, Balaghat and Jabalpur, so they are all, we are part of it. Now, my today's talk is on preconceptional evaluation and counseling for women with diabetes, a window of opportunity for a primordial prevention. So multiple things in one basket, and I'll try to justify the topic given to me. Thank you very much once again, Ankit and Vrang sir. And before I forget, I invite you for the Hello Diabetes Academia. This is the 13th Hello Diabetes Academia on 19, 20 and 21st of June. So please lock your dates. And don't forget to visit to join us in Bangalore for the 58th National RSSDI meeting. I don't have any conflict of interest for this particular session. We'll have introduction, preconception, counseling, care, and the queries of women with diabetes, and of course oral drugs, insulin, and a take-home message. Now this is one of the very important slide we have, is the number of type 2 diabetes of childbearing age are increasing. The trend of obesity and physical inactivity, many of the speakers have told just now, and it's growing. Women continue to delay their childbirth until their late 20s or beyond.
Sorry to interrupt you, sir. As we are starting with the scientific session, I would like to invite chairpersons.
Please, please, please. That's why I was waiting for it. That's why I took a permission.
Yes.
Should I start? You said no, so I thought it's okay. Please, please.
Dr. Sangeeta Srivastava, Dr. Roli Bajpai, Dr. Rakhi Bajpai, Dr. Komal Jain, Dr. Sneha Metwani,
यहाँ का भी चालू है, इसलिए गूंज रही है आवाज. यहाँ का बंद करेंगे तो हो जाएगा.
Dr. Kusum Jain.
Madam, with your kind permission, should I continue? Yeah, please, please. So when every one of you will accept this fact that when we were all born, our mothers were in 20s. Some of them even before 20s. And when nowadays, if I go through the data available to us, everyone says it's around 30, 28 plus 30. Marriage is getting in 27, 28, then you have to enjoy your life, and then you get conceived. So it's 30. So age of marriage and childbearing is going up. And we have to understand the risk associated with diabetes and pregnancy and describe the ideal candidate. Who is an ideal candidate? What are the contraindications for pregnancy? That also we need to understand. When you talk about primordial prevention, it's the fetal overgrowth and the long-term implication. If you have a macrosomic baby, or if you have a baby who has IUGR or who has low birth weight, both the ends, low birth weight as well as the macrosomic baby, both of them are at high risk of developing diabetes and obesity in their adult life. And this is a fetal neonatal obesity, which will ultimately get turn into child obesity. I'm sorry, you will not be able to see because of these chairs. And then will be adult obesity. And this will go on if she is a female, and it will continue. So gestational diabetes is a harbinger for the vicious cycle of diabetes and obesity. There's a vicious cycle. You have an obese woman delivering an obese baby, and this baby is a female again becoming an adult obese, and this will again deliver another obese baby, either a boy or girl. So this will continue. This vicious cycle we all have to break by hook or crook. Then only we can think of primordial prevention. Those who are not aware about primordial prevention and difference between primary prevention, primary prevention means those like I don't have diabetes, I should not develop diabetes, that's a primary prevention. Primordial prevention, a baby is in the womb and you are focusing the intrauterine environment for the prevention of adult onset disease. That is what is primordial prevention. So you have maternal nutritional climate. I feel some of the speaker has talked about the micronutrient deficiency. We also talk about hyperglycemia, hypertriglyceridemia, which could maternal disarrangements could also be a pro-inflammatory for the baby. Increased leptin level, lipid levels, insulin resistance, altered placental hemodynamics. placental insufficiency, placental ischemia. All this could be detrimental to the baby because of the hypoxia and other things. And of course the epigenetic changes. You have genetic changes, which is transmission of the genes, but you have epigenetic changes, and that's why you have to focus on intrauterine environment. Before madam leaves, let me comment the thing which is there at the end. If you want to have, when you're celebrating in 2047, the 100th year of independence of the country, if you don't want a single new case of diabetes in our country, you'll have to focus pregnancy today. We all have to join hands together. It should be obstetrician, it should be diabetologist, it should be every clinician who's treating a case of diabetes need to focus on primordial prevention. This is a dream of Professor Sheshaya, who's a Padma Shri and is from Chennai. He is now 85. And it is his dream that why not to focus pregnancy. You have done everything. US has done everything. Europe has done everything. All developed countries have done everything. You go through DPP trial, you go to DPP triple trial. 20 years back, still nothing has been done. The rate of diabetes is still going up. That means we are actually missing out something. And that could be pregnancy. So you have epigenetic changes, endothelial dysfunction, and ultimately coronary artery disease, diabetes, and other things. So if you miss out hyperglycemia in the first trimester, of course it can cause organogenesis issue, because the first 6 to 8 weeks are the period of organogenesis. And if you miss out that hyperglycemia, and pregnancies are usually diagnosed after 6 to 8 weeks of, once you miss out your menses. So ultimately by the time you diagnose, your organogenesis period is already over. And that is why now the things are different. Now we say the screening of diabetes should start from puberty. Earlier we used to say 40 years, then we came to 35 years, now we say 30 years. Now we say why not puberty in women, in such women. And then of course you have other complications once you have hyperglycemia. So any woman of reproductive age who is not actively using reliable contraception may become pregnant. Periconceptual glycemic control. It's not the glycemic HbA1c at the time of diagnosis of pregnancy. It is the periconceptual HbA1c which is going to be correlated with the neonatal outcome. So you have to have a pre-conception counseling and care. Your HbA1c ideally should be less than 6 at the time of conception and not at the time of diagnosis of the pregnancy. So periconceptual glycemic control is the single and the most influential factor in the embryonic development, and you should not miss it. Organogenesis occurs before pregnancy gets recognized. Single risk reduction is most effective before conception. Weight loss pre-pregnancy, if you, it gives you a better outcome. Ovulation, metabolic profile, pregnancy outcome, all related to that. So now American Diabetes Association guideline also says that you should start it at puberty. Pre-conception counseling should start at puberty. All people with diabetes of childbearing potential, effective contraception, HbA1c to be ideally less than 6, up to 6.5 is acceptable. Those who have high risk of hypoglycemia, you can target even 7. With a history of GDM, should seek preconception screening. Now, proportion of pregnancy that are unplanned. If it is less than 20 years of age, almost 82% of them are unplanned. It's around 30 years, almost 40%. So 40 to 80% of your pregnancies, if you take average age of 30, they are unplanned. Another data again says, even for the women with diabetes, only 26% of them they are planned. Maybe 75% of them are still unplanned pregnancies. So what are the things which you need to go for pre-conception counseling care? You have to go for fitness. So madam, this is a new concept we have started and possibly started by me across the country. Now we should have, you have fitness for cataract surgery, you have fitness for your hysterectomy. Now I want to have a fitness for pregnancy. Why not to bring this concept? If you start this fitness for pregnancy, I'm sure you will certainly go for retina evaluation, you will certainly go for vasculopathy, you will certainly go for HbA1c control, you will withdraw all your contraindicated drugs which are there for the pregnancy, ACE inhibitors, ARBs, statins, all these things. You can really make person fit, women fit for pregnancy, then plan your conception. I feel you will have wonderful outcome in future. That's what I need to have. Intensive education important, patient as well as the partner. It's not only the women with diabetes, it's the partner equally important. Optimum diabetes control, timing of planning. Unplanned pregnancy may cause early growth defect, congenital malformation, spontaneous abortion, and it's almost 10 times higher in type 1 diabetes, especially 10 times higher if you don't plan it. HbA1c ideally should be less than 6.5. I already told you, but up to 6 if you take a good. Higher is the HbA1c of around less than 8, 5% risk of congenital malformation. More than 10, 25%. This question is being asked to me practically in all my sessions. That sir, when someone comes to me 10.5 or 11 HbA1c, already 12 weeks of pregnancy, what should I do? So this is what you are supposed to do. You have to, we can just explain them, we can give them the prognosis. There is still 75% large chances that everything will be normal. So don't be too much disappointed if someone is coming to you and very precious pregnancy. You can certainly, of course, we can have some discussion. The 10 important question every woman who is coming to you for planning and fitness for pregnancy is going to ask you, what are those? Does that impact a woman's ability to get conceived? Yes, it can have delayed menarche, early menopause, delayed ovulation, longer duration of diabetes, later onset of menarche. 20% of them, they fail to conceive within 2 years of attempts. So this is data for this earlier onset of diabetes have higher daily dose of insulin. What is the risk of to the baby? Sir, I have got diabetes. My baby will my baby have diabetes? If I have type 1, will the baby have type 1? If I have type 2, will the baby will have type 2? So it is very rare for a newborn to develop diabetes. Very important positive message. If the type 1 diabetes has occurred of more than 25 years of age, risk is only 1%. But if I can possibly use the marker, yeah. If it is less than 25 years, is 4%. So maximum risk of developing type 1 diabetes to a type 1 mother is not more than 4%. If both parents have type 1 diabetes, the risk is not known, but it seems to be higher. Offspring of women with type 2 diabetes, almost double the risk of general population. If I say Jabalpur has a risk of 14 or 15%, I'll say 30% to type 2 diabetes children. Do women with diabetes have increases of spontaneous abortion? Yes, almost 18% in type 1 diabetes, and positive association with poor glycemic control. It was related to glycemic control at the time of conception. I told you it's a toxic milieu in which the embryo is developing is the causative factor, result in degeneration of the embryo, abnormal placentation and vascularization, and chromosomal abnormalities rarely. Do the infant of diabetic mother have increases of congenital malformation? Almost 50% of the perinatal death in diabetic mothers have congenital malformation. Risk factors, hyperglycemia, first trimester HbA1c, if you have diabetic vasculopathy, it is high. Incidence on an average is up to 10%. Meta-analysis says that compared to type 1 and type 2. Now we have a perception. Type 1 diabetes possibly have more risk of congenital malformation than type 2, but it is not so. Women with type 2 had no better perinatal outcome than type 1 diabetes. If the blood glucose, so it's a blood glucose measures rather than the type 1 or type 2 diabetes. And these are the mean blood glucose. If it is less than 105, there is the best, but the mean blood glucose is high, you have higher risk of having various complications. This is the macrosomic baby, and this is the caudal regression syndrome, which is congenital malformation, very specific for diabetes. Does the pregnancy affect the onset and progression of retinopathy? If you have pre-existing retinopathy, there is deterioration of the retinopathy during pregnancy. Laser photocoagulation is not contraindicated in pregnancy. You can certainly go ahead with this, but rapid normalization of blood glucose can cause acute progression to retinopathy, and that is what now is being coming with GLP-1 analog also. That's what we say, that what is the cause of progression or of the retinopathy, but pregnancy as a physiological stress will not initiate diabetic retinopathy. It will deteriorate but not initiate diabetic retinopathy. The abrupt increase in the blood pressure that occurs during maternal expulsive efforts during delivery may cause acute retinal hemorrhage. So those who have severe NPDR, severe or proliferative diabetic retinopathy, they have to be careful on those lines. What about hypertension, nephropathy? So if you have nephropathy or proteinuria, that can cause hypertension and preeclampsia. And preeclampsia develops in almost 50% of the patients who have diabetic nephropathy. Increased risk of fetal distress and IUGR, almost 20% in such patients. What about diabetic neuropathy? This is not going to initiate neuropathy, and there is no contraindication, there is no deterioration neuropathy. But if you have diabetic autonomic gastroparesis, someone has talked about autonomic neuropathy, possibly madam, autonomic gastroparesis, then this is one of the relative contraindication for pregnancy. I said relative contraindication. What about hypertension effect? Hypertension, aggressive control is important. AC inhibitors, ARBs and MRAs are contraindicated. Methyl dopa, nifedipine, nebutalol, I feel all gynecologists, they know it, they use it. 130/80 should be a target ideally. What about the obstetric complication? Preeclampsia, acute hypertensive complication, almost 51% with diabetic microangiopathy. So if you have retinopathy, if you have neuropathy, then chances of having preeclampsia is high, and without microangiopathy is almost 33%. Each 1% increase in HbA1c during pregnancy conveyed almost 37% increased risk of preterm delivery. And that's why HbA1c is at most important. What are the risks associated with women with coronary artery disease? So those who have women with pre-existing coronary artery disease, pregnancy and delivery can result in inadequate myocardial oxygenation, leading to myocardial infarction and heart failure. Absolute or relative decrease in ability of the coronary blood flow to meet the demand of the myocardium during delivery. And these women are extremely vulnerable to myocardial damage, pulmonary edema in immediate postpartum period. After a vaginal delivery, there is almost 60 to 80% increase in the cardiac output. And that is why we have to be careful, and that's why Caesar seems to be better option here. What about statins? Doctor, my patient is already known type 1 and type 2 diabetes, already on statin therapy. Should we continue? Ideally contraindicated. But very recent guidelines of 2025 is some circumstances like familial hypercholesterolemia or prior atherosclerotic cardiovascular disease event, statin therapy may be continued when the benefit outweighs the risk. So this is a new guidelines for you. Aspirin, everyone knows, low dose aspirin is to avoid preeclampsia. Then we have to have folic acid, that also everyone knows. I'm not emphasizing. Smoking alcohol, I don't think Jabalpur, we are very common, but Nagpur it has become now gradually increasing. We have to be careful on those lines. Few words about GLP-1 analog, because everyone now we talk about GLP-1 analog. Madam, this is one of the drug which is now being used for obesity. And those obese women who's planning for the infertility treatment, now many of the infertility clinics, they are using this before getting conceived. And they have found it to be better when it comes to little weight loss of 10%, 8% weight loss, and then planning for pregnancy have a better outcome. That's what they say. But then whether it can be given in pregnancy, but I'll take 3-4 minutes more if Dr. Bhardwaj, you allow me. Yeah, okay. So do GLP-1 analog increase the risk of congenital malformation? The risk of congenital malformation, general population 2 to 3%, with diabetes 5 to 10%. There is no direct link of this particular molecule. These are the data which has come from those patients who have already were receiving GLP-1 analog and have got accidental pregnancies. So not too much of the risk of congenital malformation here, and different countries. So at this moment of time, carry home message is there is no studies examining the periconceptual GLP-1 analog. Data of teratogenicity is neither proven nor disproven. More studies are needed to investigate this impact of first trimester loss, congenital malformation, fetal growth, whatever we have seen. And at this time we recommend that patient use contraception while using GLP-1 analog. Now how to deal with it? When should we? Because we don't have long-term safety data. We don't know. We have to withdraw the drug. The moment of withdraw, how much is going to be the weight gain during pregnancy, because you don't want to give it during pregnancy. So all these questions are still not being answered. But important that if you are using semaglutide, you have to withdraw minimum 2 months prior to planning your fertility treatment. And if it is tirzepatide, 1 month minimum, you have to give the gap. So this is a final message for GLP-1 analog. I'll just skip these slides. So preconception use of incretin-based therapy are now becoming a fashion kind of thing in most of the places. So if you don't control blood glucose well, maternal complications are near to hypoglycemia, ketoacidosis, and type 1 diabetes, deterioration of retinopathy, miscarriages, preeclampsia, fetal, congenital malformation, spontaneous abortion, macrosomia, IUGRs, neonatal hypoglycemia, and all that. If someone develops diabetic ketoacidosis during pregnancy, there are 50% risk of fetal death. So DKA at the time of pregnancy should be taken it very, very seriously. These are your targets. Now, type 1, type 2, you should have also take care of the hypoglycemia, so 70 to 95. 2 hours should be 100 to 120. GDM and pure GDM not on insulin therapy, you can just have the upper target, lower targets are not to be taken care. CGM we already have discussed, but your cutoff in CGM is 80 to 70 to 180 in non-pregnant state. Here you have cutoff is 63 to 140. So a lower sugar should not go below 63, above should not go above 140. And if it is a GDM or type 2 diabetes, you should try to achieve 90% TIR. In type 1 diabetes, 70% TIR, same range. Insulin is the preferred drug of choice. Other drugs to be, we will discuss it out in discussion. Management, of course, I have already told you, sometimes you may used to go for insulin pump. Who's the ideal candidate for pregnancy? Well-controlled diabetes, normal HbA1c, abscess of vasculopathy, preconception, folic acid, normal renal function, whose ability to monitoring blood sugar 6 to 8 times per day preconception or pre-gestational diabetes. What are the contraindication for pregnancy? Established coronary artery disease, active PDR, untreated renal insufficiency, low eGFR, creatinine more than 2, severe gastroparesis are the relative contraindication. The carry-on message from this presentation is, young women, diabetic women aspiring for pregnancy is on rise. Every woman with childbearing age is a potential candidate. Most of the women with diabetes can get conceived. The dedication for the monitoring and glycemic control is must. Follow the preconception counseling protocol meticulously. Screening of macroangiopathy before conception improves the safety, and indication and contraindication for pregnancy has to be emphasized. But the final message from this is, remember that 90% of the diagnosed pregnancies, especially in India, are still accidental pregnancy. Promise sir, galti se ho gaya. Ab galti se ho gaya becomes a headache for us. They do galti, but we are the people who are supposed to. Madam, this is very, very important because I am addressing everything to Madam because I am highly impressed with her deliberation. Long-term outlook of the offspring of diabetic mother, the glycemic control can be maximized to the extent that the baby or the mother, the baby doesn't recognize that the mother has diabetes. That could be the first step of prevention of obesity and diabetes in the offspring. This is what we want by 2047. No new case of diabetes should come to enter in our country as a newborn, and that's as a person. So today we have to take care of pregnancy so that after 20 years we can do that. Focus on the fetus for the future. That mantra you should never forget. Focus on the fetus for the future. With this, I stop here. National GDM Day. India is the only country in the world. You have got National GDM Day on 10th of March, which is the birthday of Professor Sejia. Madam, 14th November, the birthday of Benting. We celebrate World Diabetes Day. You started with Benting today, Frederick Benting. Here, Dr. Seshaya's birthday, National GDM Day, and we should do education and empowerment program like we do it. Prega Talk. Prega Talk is now become very popular. This is one of the program, public awareness initiative, which is being done in all 22 languages which are there in the Constitution. We have done first cycle, we have completed second cycle, and recently, last week, we have done the last one, Chhattisgarh, this Friday, day before yesterday. So we have completed now the third cycle, and on 10th of March, again, we'll be starting the fourth cycle of Prega Talk. And we already done in Bundelkhandi language, where promise and other things other people have done. We have done this now, last was Chhattisgarhi, but we have done in all 22 language. We missed out in the first and second cycle Manipuri and Nepali. So now we have done Manipuri as well as Nepali language, and now had a word with South Asia countries, and now we are entering into Tamil and the Sri Lankan language. There is one language, Singali. So we are going to have those two languages in very few after in the fourth cycle, maybe the next month. So it's that most important for all of us to focus on education. So take off my message. I feel I have already told you. With this, I stop here. Thank you very much for patience listening. You might be surprising why I have kept this. This is a fruit cake. Those who have not seen this slide, but many of you have seen it. It's a fruit cake. So instead of cutting the cake and cookies, which is hydrogenated fat, which will further damage your endothelium, you should cut the fruit to celebrate your anniversaries or birthdays. And this campaign and mission again is going since almost 30 years. So don't cut the cake, cut the fruit to celebrate any good occasion. Thank you very much.
Thank you so much, sir. It was indeed an encouraging talk. Over to the chairperson.
Thank you so much, sir. We always like to listen your talks because you come up with your new concept. And here also we have listened primordial control of diabetes, especially during control of glycemic control during periconceptual period, not only for the female but also for the males. So thank you so much, sir, the way you have given your insightful talk. Thank you so much. And I would like to thank organizers, Vrand sir and Dr. Ankit for giving me opportunity to chair the session and for the felicitation also. Thank you so much.
Thank you so much, chairpersons. I request our chairpersons to kindly come on stage to present memento to our speaker. Please.
My memento is already given.
Your concept of 2047 is very good. We will work very hard for it, and I think we will be able to achieve it.
So nice of you. Thank you very much. Thank you.
Dr. Kanika Seth is there with us.
हाँ, ये लेना है आपको.
Dr. Kanika, please join on stage. Chairpersons to present memento to our speaker. First, a huge round of applause. Requesting Dr. Kanika to kindly present memento to our chairpersons. With this, we quickly move on to our next session. For the next session, I would like to call upon chairpersons, Dr. Ravi Kumar, Dr. Colonel P.N. Gupta, Dr. Rajkumar Jain. Speaker for the session, Dr. Parimal Swami. I again call upon our chairpersons, Dr. Ravi Kumar, Dr. Colonel P.N. Gupta, Dr. R.K. Jain, Dr. Rajkumar Jain. Over to the chairperson.
With this, we'll move to the next session in which I invite Dr. Parimal Swami. I don't think he requires any introduction in the town. He is a well-known diabetologist and a well-known researcher. We always see his articles in the WhatsApp group and everywhere, and we learned a lot from him. Dr. Parimal Swami, please go ahead with your talk on diabetes recovery.
Thank you, sir. Thank you very much. Respected chairperson, my seniors and friends, we are now in the era where the diabetes remission is in vogue. Everybody is talking about, right, in every social media that diabetes can be reversed. But when you see the data, then there are certain things which come out that the diabetes reversal or remission is not a reality in real life. And there are many, many patients who go into the remission and then they again bounce back to becoming a diabetic again, and this is sometimes very, very heartbreaking. So we are sort of thinking about this, and we have come out with a relatively new concept that is called a diabetes recovery or any disease recovery. I'm giving you a very, very short introduction of this concept through this presentation. This is the heat map of diabetes of the world, and you can see that India is at the top, both for the death and for the disability. So India is one of the topmost countries which are having the highest death from diabetes and highest disability from the diabetes. And when you search out the cause for this, then there is only one factor, that is called behavioral factors or the lifestyle factor, which are responsible for not only the death but also the disability generated by the diabetes. And this is true about many, many chronic diseases. So what happens if you change your lifestyle, you change your diet, you start doing regular exercise? The data is illuminating that if you follow an ideal lifestyle or a reasonably good lifestyle, then you can have almost 60% reduction or attenuation in the cardiometabolic diseases. So again, the lifestyle comes out as a very, very important or the decisive factor for the control of cardiometabolic risk factor, also the cardiometabolic disease outcome. So you will be having less of death and less of disability through this. But how to implement this in your day-to-day practice or real life practice? So we have created a research-based organization that is called Diavol Core, and our philosophy is that disease is a reversible system of dysfunction. It is not a single process inside the body, and lifestyle is a biological intervention. It is not a simple advice. Recovery requires precision, sequencing, and dose control of everything which you are going to use for your patient, the lifestyle as well as the medication. And why it is different? It moves beyond prevention and risk reduction, targets dominant biological phenotypes. It doesn't mean that the patient's cholesterol is increased. It is not only the cholesterol. There are certain disease process which is behind that increased cholesterol. It targets the dominant biological phenotypes, uses routine clinical data, so it is cost effective and creates measurable recovery trajectories. Now, prevention is a slow process, and it's a lifelong suppression of certain things. But a recovery means outcome, reduced disease expression and treatment intensity, improved metabolic flexibility, restored autonomic balance, improved functional capacity, and resilience towards the physiological stress. That is the philosophy of our concept. And with this, we come to the reality of diabetes remission. I'm not going into the definition, but here is the real life data. And only 3% of the patient will achieve remission over 3 years. So it is a disheartening process for most of our patients, and it becomes a binary thing, either remission or not remission, even if health improves greatly. So this basically, the recovery changes the focus from remission to the recovery of a disease process. So a recovery model is not a single endpoint, it's a progressive restoration of the regulation. The goal is to reverse dominant pathological phenotypes and stabilize the modifiers, which we will be seeing later. Stage system repair, and outcome is fewer symptoms, better resilience, improved biomarkers, and lower medication burden. Whereas remission means all or none. Either you go into the remission or the remission fails, and it will fail 97% time over the next 3 to 5 years. So it's a losing battle for most of us, for the patient and for the doctor. But why generic lifestyle advice underperforms? So many patients follow the good lifestyle advice, but still they fail because the advice is usually same for almost everybody. There is a mismatch between the stressor and physiology, poor durability and adherence, and you should know that lifestyle acts like a drug, and dose and target matter. So it is important. So we know the target and the particular patient type. In one patient, exercise works, sugar improves, energy improves. In another patient, exercise leads to the more stress, but sleep fixes the sugar. In third patient, exercise is neutral, breathing, certain sort of stress reduction intervention or breathing will be help. So same advice, but different results. So we have to choose one pillar, test it, and then decide if we want to keep it or we want to replace it with something else. Now, what are those phenotypes? If you see, almost all the diseases, both chronic and acute, will be having 4 major important phenotypes: inflammation, mitochondrial and oxidative damage, endothelial dysfunction, insulin resistance at the level of liver, and the peripheral insulin resistance. So these are the 4 or 5 disease driver which will determine the outcome of almost all the diseases. Now, there are certain modifiers like autonomic dysfunction, maybe physical, maybe stress related, gut dysbiosis and mental stress or the threat to the patient or organism. So the treatment sequencing is the stabilize the modifier, then intensify the phenotype specific intervention. So if you find inflammatory phenotype, no fun in advising the advice which is going to reduce the insulin resistance. Or if the patient is having insulin resistance, focus on that first and then deal with the other dysfunction. Now, what are the things which we take in our intervention? Glycemia, of course, is there, but simple metabolic panel, the lipid profile, uric acid, the anthropometric parameters, the inflammation is derived from not only the CRP, but the routine, the markers which are derived from the CBC, the functional simple test, exercise test, which can be done in your clinic within 3 minutes, and certain slightly high level of investigation to determine the autonomic health of the patient. Now, find the right system, the right stimulus, target the dominant dysfunction, and then use the lifestyle as a precision therapy. And we use the DREAMS model, which is basically the diet, respiratory training, mental intervention, which is very, very important, and the sleep training. Now, I have compared this with another model. You know what is the cost of the best healthcare or preventive package in the whole of the world? The cost of that package is around 20 lakhs rupees. So you undergo that investigation, 3 to 4 days of investigation, 5 to 7 days for the processing, and 5 to 7 days for the advice. And this is available in most of the European country. But against that, our model is very, very simple. We use the routinely derived data which is taken from the clinical data, and this can be scaled up and can be implemented in a large level of population. Now, I am giving you this example. For example, the exercise. For almost all the phenotype, zone 2 and MAF walking, which are the heart rate based walking technique, is important. Simple instrument like a heart rate monitor which can be worn on the chest or the wrist, can detect a particular heart rate at which you have to walk for 30 minutes a day. Then the strength training for selected number of patients and targeted strength training to improve the muscle resistance, muscle insulin resistance, and hepatic insulin resistance. Then certain small exercise which can be done within 3 minutes to improve the insulin resistance. Very high intensity exercises are restricted, not to be done every day, and yoga and mobility depending upon the patient's phenotype. Start the exercise, stabilize the patient, and then you can further progress. So that way there is no more stress, the adherence is better, and patient does not feel overwhelmed. Now, this is one example. Somebody was asking about the diabetes distress and diabetes depression. This is one example from the mental bias map of that particular intervention. The PHQ means it is a screen, depression screen of 2 questions. GAD means anxiety screen for 2 questions. And DDS means diabetes distress screen for 2 questions. So you do this in your initial workup. If the stress is low, then you go with the full intervention. If the stress is increasing, patient requires more of support and less of the intervention. There are certain techniques which will be acting for this patient. The education is a must because he is stress-free. For this patient who is here, education will not produce any of the changes. So you detect the dysfunction and accordingly you select your intervention. Similarly, this is for the hepatic insulin resistance. These are how to detect fasting glucose, HOMA-IR, triglyceride, ALT and GGT. The pattern, the contributor and the modifiers. And then you come out with change in the diet, meal timing, movement, certain yoga which are now there in the literature which can help the hepatic insulin resistance, certain breathing technique which will reduce the hepatic resistance if done during the night time, and certain bioactive substances, food and food substances which will address the hepatic insulin resistance, and you again go through the 4-week process, not very long, and then again you will target the hepatic dysfunction, insulin resistance, check the blood sugar, which is working, whatever is working you keep it, whatever is not working you remove it. So there is no extra burden on the patient to follow a lifestyle which is all encompassing. So less overwhelming for the patient. This is again for the dysbiosis of the gut. So change the diet, the movement which are important, which are evidence based to improve the gut dysbiosis, certain yogasana, certain breathing which can sort of influence gut dysbiosis, supportive thing like probiotics, glutamine, aloe vera, sleep and behavior changes, and then again symptoms are decreased, you remove each intervention which is not working or which is marginal. Keep the intervention which is working and which is very, very important. But again, all these things are not possible by a single human being, and in clinical practice it may become an unreality, say just a research tool or a novelty or a trivial thing. But with the advent of the artificial intelligence, you can take the data from the patient, the rules can be set up by us, or rules are set up by us, and then you can create a perfectly healthy lifestyle which is easy to follow and which will sort of impact only those phenotypes which are disturbed. Does it work? Yes, it works. We have already conducted a trial, it is published, and in this trial we have checked the diet part of this DREAMS model. We have basically compared the diet generated by the AI platform with the diet generated by a trained dietitian. And you can see this is the before intervention, the body mass index, the statistical value, the difference is significantly significant. Reduction in HbA1c, reduction in serum triglyceride, and reduction in serum cholesterol. Though the dietitian generated diet produced also the statistically significant changes or beneficial effect on the patient outcome, but AI generated diet, which was basically more of phenotype based diet, produced better changes as compared to the dietitian generated diet. This is the data from the comparison with the baseline AI diet and dietitian generated diet. So again, it was statistically significant on many counts, but numerically AI generated diet outperformed the dietitian generated diet, though the same dietitian trained the AI platform. So they created the rule, the AI followed that rule, and then it created a better diet, or say diet which was easy to follow by the patient. So the results that with improvement in prompt creation process, artificial intelligence platform generated diet may become a cost-effective way of providing personalized nutrition at a community level. So now we are using this model in our clinic. It is slightly more cumbersome, it takes say 10 to 15 minutes, but only 10 to 15 minutes for one patient. So patient who is willing to say give this time, and the data is simply whatever data you generate for your patient in your day-to-day practice. Simple lipid profile, a basic biochemistry profile, CBC, 2 or 3 tests which can be done in clinic by your assistant within few minutes. So this data, basically the AI platform uses the data and generate the lifestyle advice for that particular patient. So my take home is diabetes remission is possible, but durability is difficult and relapse is common. A remission only goal can become a frustrating battle. Disease recovery reframes care as ongoing phenotype reversal and system strengthening. This enables measurable, durable health enhancement and beyond drug-free glucose control. So a patient does not have to change that thing. And my final take home is that we are trying to fill the ocean with a glass with our pharmacological approach, but not seeing the stream of opportunities which can be provided to us with the help of the lifestyle intervention. So thank you very much for patient hearing. And these are the references which we have collected over the few years period. Thank you very much.
Thank you so much, Dr. Parimal Swami. That was a very nice talk from you.
Thank you, sir. If anybody having question, please go ahead.
As we are running short on time, I request our chairpersons to kindly come on the stage to present memento to our speaker. We have Dr. Akash Seth with us. Dr. Akash Seth, yes. Clapping. It's always a pleasure to listen to Dr. Parimal Swami, sir. I request Dr. Akash Seth to present memento to our chairpersons as well. For the next session, I would like to call upon to chair Dr. Pradeep Dubey, Dr. Vijay Pratap Singh, Dr. Shweta Pathak, Dr. Pallavi Londe, Dr. Sameer Jain. To chair the next session, Dr. Sameer Jain, Dr. Pallavi Londe, Dr. Shweta Pathak, Dr. Vijay Pratap Singh, Dr. Pradeep Dubey sir. Our speaker, Dr. Sudha Rao. Dr. Sudha Rao, is she there with us? I request our chairpersons to kindly introduce our speaker to the conference.
Ma'am, Professor Dr. Sudha Rao. She is Professor and Chief Division of Pediatric Endocrinology, and she has got affiliations by Jardal Wadia Hospital for Children, Institute of Child Health and Research, Mumbai, consultant in Pediatric Endocrinology, Tata Memorial Hospital, Mumbai, and she is consultant in Pediatric Endocrinology, Jupiter Hospital, Thane. She has got various publications in peer-reviewed index journals, almost 16 book chapters, and she is also editor-in-chief, Wadia Journal of Women and Child Health. Her area of interest are pediatric endocrine disorders, disorders of sex development, and puberty. Over to...
Thank you so very much. I know I'm between you and the lunch, and I would try to be as brief as possible. Thank you, Dr. Bharadwaj, for inviting me here. It's always a pleasure to come to Madhya Pradesh. My alma mater is Gwalior, and I feel very connected to this Maharashtra state, though I am currently based in Mumbai. So this topic which has been given to me, I will try to finish it in the next, I think, 12 to 15 minutes, is on diabetes in infants and neonates. Having heard such a wide variety of diabetes and the primary prevention, primordial prevention, as well as the various other aspects which are not purely very clinical, but contributing to the care of individuals with diabetes. Looking at the infants and neonates and their care is really very challenging, because often it is something the baby is born with. Coming to the newborn period, hyperglycemia in neonates in by far is rare and transient. And the definition here is often by an operational threshold. It's seen. So blood glucose level, which is more than 125 milligram per dl, is defined as hyperglycemia. And it is often seen in extreme low gestation age babies or extreme low birth weight babies. And the mechanism in which they have this, which is usually often transient, is because of decreased beta cell mass, insulin deficiency, insulin resistance, all the things that you can think of in the form of pathophysiology of hyperglycemia exist during this period of transition from the intrauterine anabolic state to the extrauterine catabolic state. So often these transient events happen contributed to iatrogenic factors and inherent adaptive issues in the baby, especially like a premature or a small for gestation baby. Sepsis, systemic fungimic sepsis, use of inotropes, adrenaline, noradrenaline, dopamine, and the stress factors, use of drugs like xanthine, glucocorticoid in this neonatal period, and some inborn errors of metabolism like propionic acidemia and beta-ketothiolase deficiency, which can present as transient, mimicking like a decay. But when you speak of neonatal diabetes mellitus, it is actually a severe hyperglycemia presenting within first 6 months of life, requiring insulin for more than 2 weeks. And the incidence is fortunately very, very rare. It happens 1 in 90,000 to 1 in 1,60,000 live births. And many of them, like I mentioned before, is transient, nearly half of them or more, and some could be permanent. And genetic analysis in this age group has not only has got a diagnostic implication, but also has a therapeutic importance. These babies present often with failure to thrive, and the hyperglycemia persists. They may, if not asked a direct question of excess diaper change, may present with polyuria avid feeding, always hungry, cranky babies, and they may also present with the extreme of diabetic ketoacidosis. To understand this process, let us look at how the beta cell actually functions and how can we understand the pathophysiology of this neonatal diabetes in this perspective. To the fed state when the glucose is available, it enters the cell membrane through the glucose transporters, which in turn go on to the process of glycolysis, producing ATP molecules, which increases depolarizes the cell membrane. The beta cell membrane gets depolarized. I hope you can see the cartoon here. And then this in turn opens the calcium gated channel, causes the calcium to come intracellularly, and the insulin secretion happens. This is what happens in a fed state. But interestingly, most of these steps are intricately genetically controlled. So we have this gene ABCC8, KCNJ11, and then you have the insulin gene, the nuclear gene like GLS13, you have the endoplasmic reticulum gene, which is EIF2AK3, the Wolfram syndrome gene, the 6q24, the GCK, and this the Wolcott-Rallison related syndrome gene. But there are also genetic disorders which manifest in the form of pancreatic aplasia or hypoplasia, affecting the pancreatic morphogenesis. So there are lots and lots of genes which are now currently being discovered. As of maybe, when I'm talking, maybe as of yesterday, there are about 30 genes and more which are implicated in this monogenic form of neonatal diabetes. So the diabetes gets classified as transient, permanent, or syndromic, and each of these conditions can have associated features, like abnormal pancreatic development. These are the various genes which are affected, but what is more interesting to us as clinicians is to look for features associated. For example, if a child with neonatal diabetes or diabetes in the young age group, you do an ultrasound, you find a renal cyst, or you find developmental delay, umbilical defects, congenital heart disease, you have cerebellar hypoplasia, you have features of, say, gallbladder, intestinal atresia, gallbladder agenesis. Those are associated features. If they are present, maybe you can definitely think or guess in terms of what could be the underlying genetic abnormality these children might have. So besides pancreatic development, there could be abnormal beta cell function, wherein you have the commonest form, which is the Fanconi-Bickel syndrome, also seen in older children. This is called as the type 11 GSD, where they have hypergalactosemia and liver dysfunction besides having postprandial hyperglycemia. You do have this Rogers syndrome. Maybe if I have time, I'll show you some cases. And genes which cause destruction of the beta cells, like Wolcott-Rallison syndrome. For some reason, in our ethnic population and in Southeast Asia, this genetic defect is more commonly seen. In my own center, we have something like 6 to 8 of these children who present with underlying liver dysfunction, evolving skeletal dysplasia along with diabetes. So what are the clinical features which would give you a clue to think? So in a child presenting less than 6 months with hyperglycemia, diabetes suspected, look for neurodevelopmental disability, look for presence of diarrhea or exocrine pancreatic insufficiency, thyroid dysfunction. This could be both central or primary hypothyroidism. Transient or relapsing or remitting could be in the transient genes. Family history of diabetes, we know about the GCK, we know about the various forms of monogenic diabetes. Kidney structural or functional issues, liver dysfunction, skeletal abnormalities, visual impairment, deafness, and a transfusion-dependent anemia, which is something like a megaloblastic anemia, which can have an underlying thiamine-responsive form of diabetes. So let us go through a couple of case scenarios. This 1-month-old baby presented with fever, polyuria, and multiple episodes of vomiting. He was born slightly small at birth, but he had gained at 1 month a weight of 3.25. He was born of a non-consanguineous union, but the mother's sister also had something similar and had died at a young age. So when we investigated this baby, on admission the pH was 6.9, the bicarb was 2.4, 600 of RBS, and urine ketones were 3+, and the pancreas were normal. So we had a scenario of neonatal diabetes mellitus presenting in diabetic ketoacidosis. So how did we treat? We treated as DK as per. There are actually no good protocols for neonatal management. There is a lot of struggle happening with multiple challenges in terms of insulin dosing, how to deliver the insulin, because they need very, very tiny doses. So there are no diluents which are easily available, but we do it in normal saline and we give diluted doses of insulin. They do best with NPH lente because glargine is largely not recommended in this very young babies. So after treatment, it is very important, after stabilizing, very important to do a genetic analysis, wherein this baby was found to have a KCNJ11 heterozygous autosomal recessive form of pathogenic mutation. When we say KCNJ11, the problem is in this potassium ATP channel, which remains open, and hence the potassium is not, the depolarization does not happen, and the insulin release does not happen to run it through fast. That's what is the process. That's what is the mechanism why the insulin does not get exocytosed and you have an insulin deficiency state. But 50% of these cases are from non-consanguineous union, and 20% of these KCNJ11 mutations can have this DEND syndrome, which is developmental delay epilepsy neonatal diabetes syndrome. And the revolution of using sulfonylurea against these channels, ever since it was discovered in 2004, has given a lot of scope of shifting these children in the presence of these mutations to sulfonylurea sensitive potassium ATP channels disorders, to shift them to sulfonylurea. Like we did in this case, we transitioned the child from NPH lente to glibenclamide progressively as per a standard protocol of care. And now he is 15-year-old and is growing well, and that is what the literature also says. Many of these children do well on chronic sulfonylurea therapy, and they are well controlled in terms of their glycemia. So coming to another scenario, this 5-month-old baby presented, again born SGA, presents with 507 milligram per DL of sugar and pallor, severe diabetic ketoacidosis. I know this is a fallacy, though HbA1c is not a very good measure in 5 months of age because they still have a lot of fetal hemoglobin. HbA1c does not truly reflect the degree of glycemia or the average blood sugar in that age group. So this baby presents with ketoacidosis, with pallor, with severe, very high levels of glucose. So when you investigate, you find a hemoglobin which is 6, there is thrombocytopenia, there is no neutropenia or leukopenia, there is anemia and thrombocytopenia, and the child is started on insulin, and I'm sure you must be guessing already. The smear shows that there were hypersegmented neutrophils with markedly reduced platelets, giving the possibility of a megaloblastic picture. This baby also underwent a bone marrow aspiration where there were megaloblasts found, but the vitamin B12 was normal. So ultrasound pancreas again was normal. So we had a child suspected to have thymine responsive megaloblastic anemia, also known as Rogers syndrome. And the mutation proved this underlying defect where treatment with thymine improved the child. So just to give you a brief about what is Rogers syndrome, it is a multisystem genetic affection disorder wherein in the early infancy to adolescence they present with hyperglycemia diabetes. 60 to 70% can also present only as anemia or may have an associated anemia. So there could be a history of a child of diabetes who's getting recurrent transfusions. So when such a history comes, maybe you should strongly think in terms of thymine dependent, meaning Rogers syndrome, and thymine treatment controls your hyperglycemia easily. Large number of them have sensorineural hearing loss, optic atrophy, and they are prone to stroke, epilepsy, cardiac rhythm disturbances, etc. So in our child, we started thiamine. The maximum dose you give is 150 milligram. So any child requiring more than 150 milligram, you need to revisit your diagnosis. Maybe it's not thiamine responsive. So this child also had profound sensory neural hearing loss. And this is a brief of the number of cases we've had at Wadia. We had, I'm sorry, this slide is not nicely made. We have so far about 18 cases of neonatal diabetes mellitus. And then the commonest cause we have found is KCNJ11 and ABCC8 mutation and this Walcott-Rollison syndrome related genetic defect. The others are few, other syndromes are few, and it was negative in one child and it's not done in one, and some reports are pending. We also diagnosed a child of Wolfram syndrome in this spectrum. So what is the role of genetics? Coming to sum up my approach here, when you have a newborn less than 1 month old presenting with hyperglycemia, which is insulin dependent, and there is no alternate etiology for that, you are going to think alternate etiologies are these as is mentioned here. Or you have a newborn who's 1 to 6 months of age, as many of them present with monogenic diabetes, or you have an infant between 6 months to 1 year of age, you would want to do the antibodies. The antibodies come negative, and after checking your the first test you would want to do would be more like an NGS panel. If that NGS panel is not really very useful, then you may do a MLPA. And besides doing this genetics, you would also want to do the ultrasound of the pancreas, do a CBC in all infants coming to you with diabetes. Do not forget to do the liver dysfunction, because that would be a clincher for diagnosing Walcott-Rollison syndrome. And you need to do the ophthalmological and hearing evaluation in all these children. One important thing based on ultrasound morphology which you can detect is, if the ultrasound picture, of course the expertise should be there in finding out the morphology of the pancreas on ultrasound, because children it is quite often difficult. So if it is normal and the onset is between 1 to 3 months, and you have cardiac, renal, whatever anomalies, it could be a transient neonatal diabetes, and the treatment of choice could be transiently insulin. If you have normal morphology with developmental delay, ADHD, autism spectrum of disorder, there could be potassium ATP channel defect, either KCNJ11 as in Dent syndrome or ABCC8. And the treatment here initially would be giving insulin, subsequently switching them to sulfonylurea. Episodic hepatic dysfunctions along with an evolving skeletal dysplasia could be Walcott-Rollison syndrome. Here again the treatment of choice is insulin. When you have sensory neural hearing loss with megaloblastic anemia, it is the TRMA or the Rogers syndrome, and the treatment here is thiamine. When you have sensory neural hearing loss without anemia or have optic atrophy, Wolfram syndrome is your diagnosis, and you would want, the treatment of choice there is insulin. So these disorders, Walcott-Rollison, Rogers and Wolfram, they are all progressive multisystemic disease, and they need strict surveillance during their follow-up and age. When the morphology of pancreas is abnormal, there is hypoplasia or complete agenesis, you have defects of morphogenesis as in the genes. If there is an associated exocrine pancreatic insufficiency or other organ system anomalies present, you could think in terms of these gene defects corresponding to the associated abnormalities. But mind you, all of them would have a permanent neonatal diabetes, and they would, the treatment of choice, and they would be dependent on insulin. So the take-home message is, hyperglycemia in neonatal period and early infancy is rare and often transient. Hyperglycemia in the first 6 months of life requiring insulin is suggestive of neonatal diabetes. It's a monogenic disorder, fortunately often transient. Permanent forms are a heterogeneous group with multiple genetic forms, and many have multisystem affection. Molecular diagnosis of all NDMs is essential, not only to provide appropriate therapy, but also to provide the prognosis and counseling. Associated conditions like deafness, developmental delay, seizures, optic atrophy, syndromic features are pointers towards multisystem involvement. Sulfonylurea therapy is effective in some forms of NDM, especially the KCNJ11 and ABCC8 forms, and is guided by the mutation the child is presenting with. Thank you. Thank you very much.
Thank you very much, ma'am. It was a very enlightening discussion.
I think I can't hear you. I'm happy to hear myself because I'm speaking on the mic because of the noise in the background.
Yes.
Yeah.
We are extremely.
Thank you, ma'am. It was a very. Can we ask a question? Ma'am, just one question, very important for us actually. If the patient is, the children, they are on prednisolone for various disorders like nephrotic syndrome and our acute lymphoblastic leukemia cases where we give prednisolone for longer period of time. What is your advice? What should be the cutoff to start insulin? Usually we give insulin if the glucose RBS crosses more than 200.
So
what
I
is your
think,
take?
I think the diagnosis of diabetes remains the same irrespective of the etiology. So if you have any random blood sugar which is above 180, 200, or you have features of glycosuria, fortunately the drug-induced ones do not come in decades. It's a mix-up of peripheral utilization of your glucose as well as insulin resistance. But still in them, we do give insulin for a short period of time until they are on the drug like prednisolone. So it's often in, say, rheumatology conditions, and prednisolone is also used in leukemia induction, and those drugs are used. And there are drugs like L-asparginase which are used in leukemia. All of these do cause relative insulin deficiency, and they may need insulin during the duration of treatment or sometimes even a bit longer. The combination is the same: basal bolus, long-acting and short-acting.
Okay. And in such cases, do you recommend intermittent doses of steroid? Is it better than continued?
No. See, it is very easy to control sugar, but it is very difficult to control nephrotic or a rheumatological condition or treat the malignancy. Let them do what they want to do as much as is needed. It is easy to control sugar.
Thank you. Any other question?
With this, we conclude the session. I request our chairpersons to kindly come on stage. I request chairpersons to present memento to our speaker. Request Dr. Akash Seth, Dr. Piyush Jain sir, and Dr. Neeraj Baredia sir to kindly come on stage to present memento to our chairpersons. With this, we will have a short 10-minute break. That's it, because we are running short on time. Just a 10-minute break and we will resume the session. Our next speaker, Dr. Piyush Manuvia sir. Short informal lunch break of 10 minutes, and then we request you to come and join the conference ASAP. Chairpersons are requested to kindly see at what time are you going to chair the session, to please be present in the conference hall at that time. all the delegates to kindly take their seats. We are about to start with our next session. once again requesting all of you to kindly grab your seats for the power-packed post-lunch talk. Quickly moving on to our next session, post lunch session है, मैं जानती हूँ नींद आएगी, लेकिन हमारे स्पीकर इक्वली एनर्जेटिक हैं, तो आई प्रॉमिस यू To chair the session, I would like to call upon Dr. S.K. Mishra, sir. Please take your seat as chairperson. Dr. S.K. Mishra, sir. Dr. Ramesh Chavlani, sir. Dr. Amit Kinare, sir. Dr. Gangesh Tandia. Please take your seats as chairperson. The speaker for the session is Dr. Piyush Manoria, and the topic is diabetes, gastroparesis. For those who are continuing with the lunch, I'm sure you're going to miss something very good. Please take your seats.
Topic is diabetic gastroparesis, which is a very commonly seen in the OPDs
Sorry
nowadays.
to interrupt you, sir. One more chairperson. Dr. Diksha Soni. Please continue, sir.
I will
one or other drug is not working, the different drugs should be tried. The second case was a 60-year-old female with type 2 diabetes for 20 years on multiple OHAs. And she also came with postprandial pain, fullness in abdomen, bloating, nausea, vomiting for last 6 months. All the investigations were almost normal. Sugars were controlled. Sonography, CT, endoscopy was normal. We have done a gastric scintigraphy also, which showed significant 30% reduction of the food. Normal is less than 10%. So again, multiple pharmacological drugs, the physicians have also given, and I have also tried, but still nothing was improving. Erythromycin was also given from my past experience, but she was not controlled. Vomiting and the symptoms were not controlled after that. We again get a detailed history, and she was on oral semaglutide since last 6 or 7 months. And we just stopped that drug, and her symptoms get relieved. It's very important to take a detailed drug history in any patient who has symptoms of nausea, vomiting, or gastritis, because otherwise she can't improve. Diabetic gastroparesis is delayed gastric emptying in the presence of poorly controlled diabetes without any mechanical obstruction. It is seen in around 5 to 12% of all diabetics, though the prevalence we see is more in type 2 diabetes, but its association is more with type 1 diabetes. In type 1, it is seen in 5%, and in type 2, 1%. It is directly related to the duration of the diabetes. The more the duration, more chances of gastroparesis. Old age is a risk factor. It is more common in females. Any patient who having recurrent hypoglycemia have higher chances of has issues in gastric motility, and any microvascular complication suggests that the patient may have gastroparesis also. So pathophysiology is very complex, because a gastric motility is a very complex process, but it is known that it is a form of autonomic neuropathy. Previous studies have shown that persistent hyperglycemia causes vagal nerve injury. There is disturbance of the pacemaker of the stomach, that is the interstitial cell of Kajal, and also the loss of nitric oxide synthase relaxes the stomach fundus when the food enters the stomach. All these mechanisms causes the delayed gastric emptying, which is a complex process. The diagram also, you can see that the enteric neurons are damaged, the interstitial cell of Kajal is reduced, there is damage to the smooth muscle cells, and there is more fibrin in the stomach, leading to gastroparesis. So this is the normal motility. Whenever the food enters the stomach, there is funding relaxation. So you can see in the first is nitric oxide. Nitric oxide increases the space of the fundus and causes active accommodation of the food. In gastroparesis, this nitric oxide is not released, so the fundus cannot be relaxed, and there is a feeling of postprandial heaviness and vomiting. And the food is formed in the form of chyme, and there is a gastric basic contraction, and then there is a coordinated, in a coordinated way, the food is entered the duodenum in a coordinated way in a small quantity. This is all disturbed, and the main, it is known as the migrating motor complex of the stomach is disrupted, leading to this illness. 40% patients are asymptomatic, because if we do this gastric scintigraphy in diabetic, we will find that a huge number of diabetes is having reduced gastric motility, but 40% is asymptomatic. We don't have to do anything in that. The most common clinical feature is the nausea, early satiety, post severe epigastric pain, jaundice, itching. Patient should not have pain suggestive of pancreatitis. We should have ruled out that. We should exclude other causes like electrolyte disbalance can cause gastric instability. Many neurological diseases like Parkinson's, rheumatological disease like scleroderma or MCTD. Any surgery will reduce the gastric motility. So we should exclude all the cause as it's a diagnosis of exclusion. Take a detailed medicine history, GLP-1, opioid, analgesic cause, reduce gastric motility. Tricyclic antidepressants, which are very common, they reduce the motility. Any patients in outright for any pancreatic disease, they can cause anticholinergics, calcium channel blockers, sometimes removing the calcium channel blockers from the prescriptions. This improves the gastric motility symptoms, and sometimes in the constipation also, if you remove the calcium channel blocker from the prescription of the patient, sometimes constipation is also benefited. And finally, endoscopy should be done in all patients to rule out mechanical obstruction, because it can also be a feature of CS stomach, which should be a dreadful combination and a great miss for us. And at the last, if you can assess the gastric motility, the gold standard is gastric emptying scintigraphy, in which a technician labeled meal is given, and we see how much is retention after 4 hours, and the normal is less than 10% should be retained. If more than 10% of this meal is retained after 4 hours, this suggests gastric hypermotility. So the first is the normal. This is the suggests gastroparesis. We can see food is still in the stomach after this is of 120 minutes, and this shows the hypermotility. So this scintigraphy can easily check the gastric motility of the patients, but it has drawback. It is costly, not readily available. It has a radiation exposure. It's a nuclear. It is done where the PET-CT has been done. We need a gamma camera for this, and not all patients eat egg, so a gluten-free diet has also been made for the vegetarian patients. There are many other methods, but not commonly available. Like there's a breath test which uses carbon-13, and by this we can measure the gastric motility. And the upcoming is the wireless motility capsule, which can measure the motility of the stomach. These are not readily available. In the future, we may get the capsule which measures the gastric motility easily. So at the last treatment, dietary and lifestyle is the key to the treatment. Patients should be advised to take small frequent meals. Low fiber and low fat diet is advisable. Food should be adequate. Oily, spicy meals should be avoided. Any addictions should be avoided. Regular exercise. Early dinner at least 3 hours prior to sleep, and avoid lying down within 2 hours post meal should be there. These dietary lifestyles are very important. And the second is the strict diabetes control, as we all know. And one point is that the prandial insulin in the patients of diabetic gastroparesis should be given after meals, because the rise of glucose is delayed due to the delayed gastric emptying. So ideally the postprandial insulin which we give before meals should be given after meals to match the rise of glucose. The pharmacotherapy prokinetic is the key to this illness. It increases the rate of gastric emptying. It is recommended by all the societies, including the American Gastroenterologists Association. The most common drugs which we used is metoclopramide, sulperidone, and etoposide. As we all know, metoclopramide is a B2 and 5-HT3 antagonist. It can only be given up to a maximum of 12 weeks or 3 months, otherwise extrapiramidal symptoms occur. And the approval is also for 12 weeks. We do not extend beyond that. And the maximum dose is 40 milligrams in 4 divided doses. The side effect is the extrapiramidal side effects. Domperidone is the D2 receptor antagonist. The dose is 30 milligrams per day. It is safer than metoclopramide. The only concern is in the QT prolongation. It can cause cardiac arrhythmias. Etoposide is a very safe. It has no major major side effect. It is now available also, and it's very good drug. And also liver sulfide is available, but it has a side effect of extrapyramidal side effect and lactations. So if the patient has predominant vomiting, antiemetics like ondansetron, penicillin can also be added. Erythromycin is a macrolide antibiotic, but it is also a motilin agonist. It is a reserved drug, but domperidone and metoclopramide are not working. It can be given oral or IV according to the status of the patient. It should be given maximum for a month because tachyphylaxis is very common in this drug. And side effects are only minor in the form of cramps and diarrhea. Other upcoming drugs which can be helpful in the future, which is given for chronic slow transit constipation. Many studies have shown promising effect. So if your patient have constipation also, along with the symptoms of gastric hypomotility, you can add procalcitonin also. Other drugs like ghrelin agonist, bellamorelin, neurokinin 1 inhibitors, which are given by the oncologist to control the vomiting of the chemo, can sometimes be tried, and antidepressants and cannabinoids are under research. Some endoscopic treatment is also developed. Gastric poem is one of them. It includes the myotomy of the pyloric sphincter to reduce the pyloric resistance and increase the emptying. It should only be done as a last resort, or the success rate is only 60%, while the esophageal poem for achalase shows a high success rate of more than 95%. So you should remember that gastric poem should only be taken as a last resort because 40% of patients will not improve even if you do gastric poem with them. Others which are not commonly used, that is botulinum injections, stenting, and pyloric dilatation. There's a new device available in the US only. It involves surgically implanted neurostimulator to the gastric wall, which increase the gastric motility by increasing the electrical activity. It is mostly for the nausea predominant gastroparesis, but still it is not approved. Surgery was done previously, but in the event of gastric poem, this is not done nowadays. ACG has also issued the guidelines for the treatment of gastroparesis in 2025, and you can have a look on that. The complications which can occur is the dehydration, malnutrition, esophagitis, sometimes a bezoar is also formed, and it worsens the quality of life of the patient very much. It has no raised mortality, but it gives a significant diabetic gastroparesis is increasingly common nowadays. It has a complex pathophysiology, and it has varied etiologies. Detailed history is very important to rule out other causes of it. Always rule out a mechanical obstruction by doing upper GI endoscopy. Dietary lifestyle should be advised to all the patients. Strict diabetes control is needed. Different combination of drug is needed with fractile cases, and always be patient and holistic in dealing with it. Safety has been tested in the patients in old age also. We have very commonly given constipation, chronic motility, and many studies have shown that it is also increasing the gastric motility. Though it is not approved for it, level you can give because it's a safe drug. Erythromycin can be given only for 1 month. So, procalcitonin is not approved for constipation. We can give up to 2 years. Yeah, you can. But it should be as a last resort because half of the patient will not even if you do the gastric poem. So this should be in your mind because the patient undergo this invasive procedure and is not improving. It's very complex. You should find other drugs, find other drugs, details. Again check that these guidelines positives? Yeah, definitely. Of constipation.
Concluding. Thank you, chairpersons. I request our chairpersons to kindly come on stage to present memento.
In females, it is very common. Females complaining of lactation. Females, I don't give levosulfide, and in old age, it's strong cause of accident side effects. Sometimes stomatiodine also causes lactation. Dolutegravir stop, and it improves without any. Takes a month. My patient also stomatiodine is very common. Females complain that it has happened. So I just take one and one and there's no need to they go to gynecologist, prolactin levels, and then it's not needed. Just wait. In this for a month non-stop. There's no to do the MRI also. This MRI will be normal. Prolactin level can be deranged, but MRI will be normal and drug induced. If some as well is there, then definitely it is not due to drug. And if the scan is normal, you wait for a month. If the patient is on drug.
Thank you so much. I request chairpersons to kindly come on stage. Present memento to our speaker. I request Dr. Rajesh Agrawal sir to kindly join our speaker and chairpersons to present memento to our chairperson. क्योंकि हमारे पास समय थोड़ा कम है, मैं चेयरपर्सन को तुरंत बुलाना चाहूँगी अगले सेशन को चेयर करने के लिए। डॉक्टर प्रशांत पुनेकर, डॉक्टर नीरज बडेरिया सर, काइंडली टेक द चेयर। हमारे स्पीकर अभी मंच पर ही हैं, डॉक्टर राजेश अग्रवाल सर। सर फाइनली सुबह से फिर अभी आपकी टर्न। I request our chairpersons to introduce our speaker. Over to you, chairpersons.
Dr. Rajesh Agrawal. He is endocrine from PG Chhattisgarh. He is fellow of Indian College of Physicians and president of API Indore. And he is CEO of diabetes group. And he is honored with lifetime achievement award by CCSI and PMK Award, Rashtriya Seva Award, and RSDI USC Innovation Award. He is a speaker at various scientific and social forums, and he also gave CTC documentary on diabetes, thyroid, obesity, and interviewed on many national channels. He holds various offices in medical and social organization of international repute. He is international director of Alliance International, and yes, over to you for
Thank you, chairpersons. Jai Hind, everyone. So, last but one, probably, before promise, sir. So today we are discussing a very important topic, a very important issue, which we all are facing across the globe, across the race, and across the age groups, and that is obesity and subsequently pre-diabetes and diabetes and all sorts of comorbidities and complications associated with them. And
and every one of us is affected with this challenging task of obesity, increasing obesity. And this will be the flow of my talk in next 15 minutes. What is obesity? This definition is you will you will not find anywhere in the textbook. It is compiled by me that obesity is a complex, multifactorial, chronic, progressive and relapsing disease characterized by excess metabolically dysfunctional fat having potential of developing various comorbidities like pre-diabetes to diabetes, cardiovascular disease, and usually have no permanent solution. So you can note this down because this is the crux of the whole talk. This explains the treatment, this explains the etiology, this explains the pathophysiology of the obesity, glycemia, pre-diabetes, diabetes, and various complications. Obesity is increasing across the globe in all age groups. The incidence and prevalence varies from the racial distribution, and 20 to 40% incidence of obesity is there. WHO projects more than 2.6 million Indians by overweight by 2030, and 20% are found to be obese. Obesity growth rate is phenomenal in low and medium income countries compared to high income countries. You can see over here in India, from 1990 to 2022, in last 30 years, the obesity has increased almost 20 times. But in worldwide, it has increased 5 to 6 times only. So this is very important figure that low income and middle income countries are rapidly gaining weight as compared to high income countries. Urban prevalence of diabetes is about 15% and 50% of them are undiagnosed, and because of that there is increased morbidity, quality of life and increased financial burden. This chart is very important. Here you can see that about 600 million people are having central obesity and generalized obesity. And we all know that central and generalized obesity they are potential diabetes in future. So this is, we are on the verge of almost, we are having 700 million people with diabetes at risk. So this is very important, and how challenging the situation is. So we have to consider, we have to focus, all associations should focus on preventing diabetes, and as Secretary of RSSBI MP chapter, we have started educating youngsters and adolescents in colleges so that they can prevent pre-diabetes and diabetes, and remission is possible. Remission is maybe permanent or it is long lasting. So it is very important task to take care by all of us, but all the associations, including Dr. Piyush Manoria from this point of view also. So this is the prevalence in children and male and female. In last 5 years, we have seen the 4% rise in obesity, and across the age groups, overweight are more common as compared to obesity. Cardiovascular deaths have decreased in last 20 years to 30%, but obesity-related cardiovascular deaths have increased 3 times in last 20 years. So this is the paradox. We should remember, and cost of treatment is increased because of various comorbidities associated with obesity, like hypertension, diabetes, and many more osteoarthritis and infertility and so on. Post-COVID incidence of overweight and obesity and pre-diabetes also increasing because of the increased screen time, because of online working, shopping, gaming, and everything on online, and reduced physical activity. Then post-viral inflammation is also important. The two epidemics share the common drivers like genetic susceptibility leads to obesity because of insulin resistance. There is epigenetic factors like environmental factors which increases susceptibility to pre-diabetes and diabetes. And common drivers are sedentary lifestyle, ultra-processed food, sleep deprivation and stress. Why we are more worried about youngsters? Excuse me. Rising incidence and earlier onset of diabetes and complication in youngsters and more aggressive course of diabetes because of longer duration of diabetes and so more incidence of complications. Then intergenerational transmission of metabolic risk and increasing the cost of treatment and quality of life. Again, reversal is very important at this point of time. It is possible and long lasting while lifestyle modification and obesity treatment. Various diagnostic tools, not only BMI but waist circumference, waist ratio, height ratio. These are very important clinical tools. DEXA MRI of research importance, and then EOSS staging system which enables holistic assessment considering the psychological assessment, physical disability and various comorbidities. And then MRI, nutrition, other biochemical parameters are required. As such, obesity does not require any which is evident. You can say so these are the severity of obesity, and we all are aware that Asians have lower BMI cutoff for overweight and obesity. We are overweight at 23 or above and obese above 25. And this is the OSS staging system where they take into consideration the various risk factors if there is established end organ damage or permanent disability. Obesity is a mystery. It is multi-organ involvement, so there are multiple complications. Most of them we are aware, but some are less discussed, like gallstones, infertility, joint disease, gout, and incontinence. And all this is genetics plays very important role in all this. Genetics of the patient, genetic susceptibility, then genetic changes in the food by hybridization, chemicalization, chemical insecticides, and chemical fertilizers. Natural history from weight gain to insulin resistance, type 2 diabetes, that is adiposity in early life causes insulin resistance for lifelong. Excess calories induces compensatory hyperinsulinemia leading to increased beta cell stress, and Indians have inherently lower beta cell reserve leading to a faster progression from pre-diabetes to diabetes. This is very complex slide about pathophysiology. We all are aware about the hormone factors, but there are many more like inflammatory responses, vitamin D deficiency, then gut microbiota and so on. So hypertrophy exhaust tissue secretes pro-inflammatory cytokines and disrupting the insulin signaling. Reduce adiponectin secretion causes hepatic and muscular insulin sensitivity. Free fatty acid release leads to the hepatic steatosis and hepatic insulin resistance. Ectopic triglyceride accumulation in skeletal muscle impairs blood flow mediated glucose uptake. Adipocyte hypoxia triggers macrophage infiltration and causes insulin resistance. Systemic insulin resistance and persistent inflammatory response damages the beta cells. All this leads to the endothelial dysfunctions, hypertension, cardiac remodeling, and vascular remodeling are affected, and all this leads to the increased vascular events. Then there is imbalance between dysfunction of the ghrelin and leptin. You know, ghrelin is mother hormone and leptin is satiety hormone. There is imbalance between the two. Our response to the hormones from the hypothalamus are resistance at hypothalamic levels. And weight bias are very important factor in the causation of obesity, and it leads to the prejudice, stereotype, discrimination, and weight bias leads to the depression, anxiety, low self-esteem, poor body image, and substance abuse. Addiction is also very common with obesity because of weight biases. This is the most common reason for bullying, and media stigma is also important for causing obesity. Weight bias also leads to disordered eating behaviors, increased food intake, and avoidance of physical activity. Then diabetes risk at special population. PCOS have higher risk of type 2 diabetes because of insulin resistance and hyperandrogenism. Rising gestational diabetes creates intergenerational metabolic programming of obesity and diabetes. elderly sarcopenic obesity also reduces the metabolic flexibility and increases the frailty. Rural communities are undergoing rapid transition because of high calorie dense food and cheaper calorie dense food. So they are consuming more calorie dense foods and they are getting more obese. This is my paper published in IJCMD, where we have offered the point of care A1C estimation to the relatives of the diabetics who were found to have random blood glucose of more than 140 milligram. So immediately you can diagnose pre-diabetes or rule out pre-diabetes. So this was accepted there and published. Then multidisciplinary approach is required to treat obesity, and most important thing is the time. We have to spend time to treat obesity, and then other colleagues are required like dietitian, psychiatrists, gastroenterologists, and bariatric surgeons are also required. And educators are also required for educating about the diabetes pathophysiology and treatment. Then 5A model of this is developed by Obesity Canada. They ask for the permission to discuss overweight, assess obesity related risk, advise, agree and assist in achieving the targets. That is very important. And last line, remember to treat your patient with obesity according to the level of risk rather than BMI only. So this is very important point. This is very important carry home message. Excuse me. Post lunch है इसलिए पानी बार-बार लग रहा है. So this is another paper published in JAPI. This is my own paper. Pre-diabetes to be treated or not, and we will discuss later. Diabetes various management guidelines says that GLP-1 receptor SGLT2 inhibitors are preferred choice as compared to the weight gaining therapies like sulfonylureas and insulin, and the metabolic surgery should be considered earlier. Barriers to the effective management: high cost of anti-obesity medication, social stigma, insurance policies do not cover this obesity treatment, obesity clinics are concentrated on metros only, lack of time affect doctor and patient both. So patient also doesn't have time to listen and doctor doesn't have time to transfer the knowledge. Then word about at what time you have to eat. So early eaters lose more weight or they gain less weight. This is very important. I am going quickly because of the time. Then late eaters are more prone to get obesity, are more prone to lose weight, they are more resistant to lose weight. Then rapid eaters are also leading to obesity because you consume more food in shorter period of time and that caloric consumption is higher than expenditure. Then eating position is also important. In our country 50 years back, eating squatting is very common, and that is mechanical obstruction to eating. You can't eat more in squatting position because you can't sit for longer time and you can't eat for more amount. So these are the right positions which I have marked right. Then sleep. Sleep is also very important because it is a restorative process of the brain, by the brain, for the brain, and this is a study of more than 6 lakh patients, meta-analysis, which suggests that less than 5 hours of sleep leads to 55% more chances of getting obesity. Then light is also very important. Red color light or only dark, even light outside your bedroom is also very important to cause obesity. And dark releases the melatonin, and we know the effects of melatonin. Facts about diet: 74% patient cannot afford healthy diet in India. And most important is caloric restriction and calculation of the food consumed and calories spent in physical activities. Macronutrient composition is important, but most important is caloric restriction. This is the study of 2 years, which suggests that whatever the amount of fat or protein, the weight loss is not significantly different, in all the groups, whether it is 20% fat or 40% fat or 15% protein or 25% protein. What is healthy diet? Less we do to our food, the better it is for us. So unprocessed food is the most, like our tribal friends in past used to eat, that is very important. Raw, whole grains, unprocessed food, plant foods are better. Alcohol should not be ignored. It is high caloric product. 7 kilocalorie per gram of alcohol. That is, should not be neglected. It should be counted that you have consumed that calorie. Alcohol is not calculated. So that is very important. This is very important graph. This blue line is for very low caloric diet. So there is steep fall in weight, but again steep rise. Only exercise and only dieting doesn't mean much. But dieting and physical exercise both are having significant impact. यहाँ मैं एक बात और कहना चाहूँगा, just an example, 20 ग्राम का गुलाब जामुन you eat in only 20 seconds. But उसको burn करने के लिए you have to spend 20 minutes, about 120 calories. तो 20 सेकंड का मजा और 20 मिनट की मजा. So this is the beauty of caloric consumption. Then physical activity, various cytokines, myokines released from muscle contraction produces anti-inflammatory response in liver and adipose tissue. That's how it increases insulin sensitivity. Vigorous and moderate physical activity significantly lowers the hepatic enzymes, and benefits of physical activity are much more than weight loss, and they are independent of weight loss. Those who cannot perform physical activities, they should massage, or that leads to the cortisol level dropping and increase in feel good hormones like dopamine and serotonin. Obesity to be treated or not, pre-diabetes to be treated or not, reversal is possible or not, we will answer this question in next few slides. Pre-diabetes rapidly transforms into chronic diabetes at the rate of 5 to 7% a year. And reversal is also earlier at this stage of pre-diabetes. So these two are very important facts, and we have to see this, that increasing BMI leads to the increasing prevalence of pre-diabetes. So there are all varieties of this glycemic, whether it is fasting, post-prandial or prevention. The conversion rate in Asians from pre-diabetes to diabetes is very high. CVD mortality and all-cause mortality worsens as your glycemic control worsens. This direct trial has made a revolutionary change that later the weight loss higher will be the remission, and those who have lost 15 kg, 86% of them achieved remission, and 70% of those who maintained their weight loss for 2 years, they remain in remission. Why pre-diabetes to be treated? This is a study of 600 patients, and there were 3 lifestyle intervention group: diet, exercise, and diet plus exercise and placebo. And 51% lower incidence of diabetes during the active intervention period, and 43% lower incidence over the next 20 years. So this has long-lasting legacy effect. And average annual incidence of diabetes was 7% for intervention and 11% in control group. Just 3 more slides. This is Darking study. This is the longest 30-year follow-up, and this delays the onset of type 2 diabetes by about 4 years, and there are less CV events and microvascular complications. These are various anti-obesity medications. These red marked medications are available with us, but nowadays this is the era of GLP-1 receptor analog and SGLT2 inhibitors, but naltrexone bupropion is also available nowadays with us. These are various trials to prevent diabetes, conversion from pre-diabetes to diabetes, and overall 20 to 70% prevention is possible by these molecules. Step 10 trial with semaglutide, and at the end of 1 year of 2.4 milligram semaglutide, 81% patients from pre-diabetes were converted into remission. Then compared tirzepatide and semaglutide, about 800 patients, 72 weeks, and tirzepatide was found to be superior. for weight reduction and waist circumference compared to semaglutide. Bariatric surgery should be considered. I should not talk about this much. The take-home message: obesity is multifactorial, complex, chronic, progressive, relapsing disease requires lifelong management. Obesity can be considered as pre-diabetes. Diabetes is there, but obesity is a pre-diabetes. Usually some trigger for weight gain is there, may it be viral, stress or bullying or weight loss, lifestyle modification are the part and parcel of every prescription, every treatment protocol. Caloric restriction is most important. It is always better to prevent weight gain than to reduce gain weight. Difficult to sustain weight loss. Even after bariatric surgery, regain is very common, and high-risk obese pre-diabetes must be treated with the objective of remission or reversal. Thank you very much. Longer the band size, smaller will be the lifetime.
Thank you. Thank you.
Thank you, sir, for a very excellent and informative talk. You have covered the topic so nicely. Thank you.
And one more announcement I would like to make. 24th and 25th October, RSSBI at Sanchi, Vidisha will be held on. You all are invited there. As a secretary, I am inviting you for RSSBI MP chapter. Please cooperate and participate wholeheartedly. Thank you very much.
Thank you so much, sir. I request our chairpersons to kindly come up on stage to present memento to our speakers. Is Dr. Riddhi Seth with us? Please kindly come on stage, ma'am, to present memento to our chairperson. Sir, आइए please. Ma'am, आप भी आइए. Actually, we have to felicitate our judges also for the e-poster presentation, those who judged. I would like to invite on stage judges for the e-poster presentation, Dr. D.S. Behrani sir and Dr. Promise Jain sir, to kindly join on stage. Prashant sir, you'll be there. We will be felicitating. Huge round of applause. That judging is a very, very important, risky task. An announcement to be made: candidates for the e-poster presentation have to wait for the results. Results will be announced at the valedictory function. Thank you so much. With this, we quickly move on to our next session. I would like to call upon Dr. Sushil Kelly and Dr. P.K. Dikshit sir to chair the session. Our speaker is already on the stage. Dr. Sushil Kelly, Dr. P.K. Dikshit sir, and our speaker, Dr. Promise Jain. Requesting our chairpersons to kindly introduce the speaker to the conference. Dr. Promise Jain, Senior Consultant, Inventinist, Diabetes Expert. Please continue.
Thank you, sir. Thank you, sir. Thank you very much, sir. Since good afternoon, everybody, and I thank to Dr. Viren Bharadwaj, sir, chairperson, and Dr. Seth family to invite me and giving this opportunity. So my topic is the diabetes and anxiety. What are the therapeutic challenges I will face? Try to finish in 10 minutes. My 10 minutes. Okay. So I came with
the first example of Mr. or Mrs. of the X age with the RBS of 300 milligram per kg, and what will you do? I think everybody should know the answer. You will start the treatment with the metformin, glutamide, or the 5-rotating combination along with the serotonin or insulin therapy. Any concern with this treatment? Do you have any concern? Yeah, or do you want any other information? I think we should have other concern, and we have to evaluate with the very vigorously with the all things. We have to assess the patient holistically with history taking, and this is so my topic regarding the age. Since morning we have childhood obesity, pre-diabetes, pregnancies. Now at the end of this conference we have the elderly. So the Indian population is growing very fast, and it is the top on the list, and simultaneously diabetic patients are also increasing very fast, and the population of the more than 60 years is also growing fast. So what are the key factors in that Indian population is that the major trends and concern regarding this population is India is experiencing a significant demographic transition with the elderly population, which has a great health burden on the society also. Globally, diabetic patients are increasing, and of course the elderly diabetics are also increasing. By the 2045, it will be reached around 300 million in India also. So what are the challenges in the treating patient who is elderly, and the concern regarding those that arise from the incidence and progression of the diabetes and its complications? Actually, what we are seeing that I am treating for last 15 years. Suppose my first patient is of the age of that 40 years. Now he is in the category of elderly or near elderly. So now what is my job? That is a concern. Those that stem from the coexisting geriatric syndrome. There are so many geriatric syndromes. Learn by the 5 I's. We will discuss gradually. And definitely some logistically facility settings concerned regarding the availability of the doctors, availability of the caregivers or diabetic educators also. So what ADA did? ADA gave a full chapter of the 13th chapter on the treatment of the or management of the elderly population, and they gave the recommendation for I will discuss in the next few slides. So what are the key therapeutic challenges? First is the polypharmacy and the drug interaction in the elder population. Older patient has so many comorbidities getting various drugs, so they are on the polypharmacy. If patient taking 5 to 9 drugs, it called the polypharmacy, or if a patient getting the more drugs, that is the polypharmacy. So there may be a cognitive importance. This is very neglected by the physician, but it should be emphasized very thoroughly, and we should assess holistically this cognitive impairment and depression. Sometimes patient forget that taking the pills. We have to assess. आप उसको ऐसे नहीं छोड़ सकते कि पेशेंट ने बोल दिया कि मैं ना सर दवाई खाना भूल जाता हूँ, तो कितनी बार महीने में दवा खाना भूलता है? There is the point. Older patient has the frailty and functional decline. There is a risk, a high risk of the hypoglycemia in this patient. We have assessed this hypoglycemic index. There may be a complexity of the comorbidities in terms of hypertension, CKD, or osteoarthritis, knee pain, or different type of pain also. There may be the lumbar problems also. There may be varied patient profile. That means elderly is not a one group. This is the patient of the more than 60 years, you treat it. No, that should be managed individually. And the factor take taken to be consideration is what is the functional status of the patient, what is the life of expectancy of the patient, and what we can get from the support system. So IDF comes with guideline, and they emphasize personalized diabetes care, which is based on the functional status of the patient, comorbidity of the patient, and they target the HbA1c from below the 7%, and they focus on the safety of patient. First, safety is very important, maintaining independence of the patient and quality of life with the different glycemic goals. I will be showing the different glycemic goals in the different populations, and we have to prioritize symptoms management and avoiding hypoglycemia is the main important point in the treatment or management of the diabetic patient. This is the functional categories given by the IDF category 1, who is the functional, fully functional or independent with any program. Second is the grade category 2, which is the patient functionally dependent, which has the two categories of category 1, including frail patient. Category B is including basic patient, and lastly category 1, that is the end of life care for the patient. So what are the key management areas? We have to individualize the treatment according to the category. We have assessed patient holistically. We have to assess annually, 6 monthly, or every 3 months, monthly, according to the patient condition. We have to inquire each and every drug of the medicine list, including मुझे नहीं लगता कि लोग ना पेशेंट की दवा मंगा के देते हैं कि आप दवा most of the mistake comes because if you write a medication or this patient take the PPI also, patient taking antacid also, and other different types of they are taking. They have the more problem side effect reaction. So we have to evaluate the medications. First important point is if you are getting one time hypoglycemia, most of the time the hydro patient get the fracture and he never come to the clinic because any neck or femur fracture and so one mistake can lead to lifetime. We have to evaluate the geriatric driving should be avoided at patient's condition. Diabetic educator, dietitian to, I am working with the B2. This is a platform from the Delhi, Dr. Naveen Agrawal sir. What I am seeing that the patient elderly is very happy with us because they are not going to any clinic, not driving at that time, and they simply take the consultation, and my diabetic educator call every 2 or 3 days asking her for her blood sugar level automatically in the air. And if there is a chance of hyperglycemia, diabetic educator call him or her, and they advise accordingly. So this is the 4 M's framework for any patient of the diabetes. I am not going to detail everybody should from PDA guidelines. And these are the assessment tools, should not go into detail, but few of them I am using in Apollo Hospital, like that cognition, frailty measures, clinical, hypoglycemic risk, we are asking directly, and definitely nutritional assessment. For biggest challenge in the treatment in the elderly diabetic patient with hypoglycemia, and ADA recommends that to certain and address episode of the hypoglycemia at a routine visit because older adults with diabetes have a greater risk of hypoglycemia, especially when treated with the hypoglycemic agent like insulin or sulfonal inhibitors. This is the class 3 recommendation. In these patients, PGM also is important, and along with it, they are coming with the guideline or recommendation for the insulin pump also. So automated insulin pump delivery system, mechanical insulin delivery system, other advanced, have the different recommendations. One important point is the neurocognitive risk. I think Dr. Bharadwaj will be taking the diabetes and brain and last, so I am not doing the details, but we have to know that type 3 diabetes, that is the diabetes. So that is to the and the most of the patients developing this type of the symptoms after the 60 years along with the Alzheimer's disease or isolated from the Alzheimer's disease also. Here I am telling that if you are using any of the drugs like you have or the targeted blood pressure, definitely. So what will be the glycemic targets in this particular population? So if patient is healthy, the rational HbA1c goal is the less than 7 to 7.5. If patient has the complex intermediately some type of the comorbidities, it will be better to achieve less than 8 of the HbA1c. And if patient in the end of life care, like the patient has the any metastatic disease, cancer patient, or his ejection fraction is very low and not more than 1 year of the life expectancy, I think there is the no HbA1c target. You should treat accordingly. If he want to take I think if he want to take a Rasgulla, allow him and give him the empathy also. So how will you achieve this? This is implemented as a plan. You should discuss with that patient also if he understand properly. Speak loudly, because most of the patient has the hearing difficulty in this population. So they understanding one sentence, second point is with the forgotten. So you have to assist every visit. There should be a team approach from the physician. They involve the diabetic educator and interdisciplinary care team also, and educate patients. We have to QM approach for the medication. Start with the low dose and go slow. Lowest effective dose should be given and to achieve this targeted HbA1c level. You can use any drugs. You can not use every drug in that elderly population, but metformin is the most important agent, but it is contraindicated if patient has the GFR less than 30. Insulin is recommended, but which insulin? So this is the simplified complex insulin therapy given by the ADA. In this chart, you have to use only basal insulin in the lowest dose, given in the morning hours, avoid in the night and do not use mixed insulin. One practical point is that if you want to give the insulin, like short-acting insulin, you give after the meal. What amount of that patient is taken at that time, we don't know. So the who is giving the insulin to the patient, like the nurse or his nurse. So if patient take one chapati, you can give only for 4 units. Like that depends on the glycemic index of that patient. There is definitely nutritional consideration in that. There are just so many problems you have to assess. One important point, how many you are inquire for the metformin patient taking. The metformin tablet is the big size. So most of the patient taking that metformin by the crust, उन्होंने घोल के पी लेते हैं. So they goes to the Dr. Piyush Manoria. For what? their stomach is bloating, their GI. So that's why we have to inquire this type of the side effect of the metformin if you are present. So finally, we are in well position to support people with the diabetes in elderly. We have to assist elderly with diabetes in clarifying and documenting their values, preference and goal for care. Research shows that elderly with the diabetes want to discuss end of life care plan with their problem. If you give some time to them. So I conclude with this: the management of diabetes in older adults necessitated a person-centric approach that prioritizes comfort, symptoms management, quality of life and the preservation of dignity of that patient. Thank you very much.
Thank you so much, sir. Over to the chairperson.
Thank you, Dr. Abdul, especially for asking that you have highlighted a very weaker section of the society who is very adamant for taking their medicine or their meals specifically. The patient, just for three things, if they are feeling something, little weakness, they have taken rasgulla or something sweet because they are always keeping in mind that their sugar is going to down.
Yeah, so they are very
So this is very good talk you have delivered, sir, because slow and careful management of the elderly is very, very important. Thank you very much.
Actually, I thanks to all of you and Dr. Ankit who has given this topic. I learned a lot of things. When I got this topic, I apply the same things in my regular patient. Actually, I am looking the health check rural department in the Apollo. We have approximately 50 patients per day, and out of them, the 4 to 5 the CGHS vein patients are there. They are approximately 30 years diabetic. And if I told them you can take this one, they are getting more on me. एक रसगुल्ला खाने से यदि शुगर बढ़ रहा है, तो टारगेट हमारा 8 है, तो they are happy because with this gulab jamun or anything or fruit, they can eat one chapati.
Thank you so much. Indeed, a very good talk from you. I request our chairpersons to kindly come on stage. I also request Dr. Akash Seth to come on stage, please. Chairpersons kindly present memento to our speaker, Dr. Promise Jain. Requesting Dr. Akash to present memento to our chairpersons. Meanwhile, I would like to call upon to chair another session Dr. A.S. Bansal and Dr. Priyank Chaturvedi sir to please take their seats as chair. Speaker for the session, Dr. Manoj Indurkar. Requesting chairpersons to kindly introduce the speaker.
Senior diabetologist, former dean of SS Medical College, over 25 years of clinical and academic
Thank you. Once again, thank you to Bhardwaj sir and Dr. Seth to invite me. And he has given a very good topic of students. So my topic topic which has been given is obesopathy and ketogenesis. There are two aspects. One is obesopathy. That means it is a sick fate. All the non-communicable disease, either it is a cardiovascular disease, diabetes, obesity, all related to the fate. So obesopathy is nothing but it is a sick fate, where there is an excessive proliferation of fat cells, there is an excessive release of free fatty acids. And another aspect, there is a ketogenesis, where there is a more of lysis of the fat cells, there is a more of lipolysis, and that